So a little bit about Joe. Most of you may, or some of you may or may not know this. He's a native of New York. He originally got his bachelor and MS from St. John's University, and then, as I mentioned, did his graduate work at Indiana University, MD, PhD. After residency training in anatomic pathology, actually, I got a slide here I can go forward on. Does it work? Well, I made this very easy, yeah. So you can see some of the things he's done there. But did a fellowship with Heinz Furthmeyer here, and that's where I think sparked his first interest in matrix biology and endothelial cells, and then joined the faculty here in 1980. Rumor has it, Joe can confirm, I think his generous startup package for his lab at Yale was $5,000, Joe? $25,000. Oh, yeah, okay, huge. So we're still trying to get back to that point, but the new hires have been a little more expensive, yeah. So this is an early picture of the department. I think those of you can recognize many of the players there. I think, in fact, many are in this room. It's a little scary, but yeah, go to the next one. A little close-up. There's Joe earlier. This is Heinz Furthmeyer, for those who don't recognize, the fellow that Joe trained with. We don't know him. We won't talk about that one. So I think just to summarize Joe's career a little bit, Joe represents really all that one could ask of a real triple threat faculty member. He's had continuous funding for 37 years from the NIH and the American Heart Association. In 1999, he was awarded a 10-year merit award from the National Institutes of Health. His studies have made major contributions to our understanding the role of the matrix on vascular biology, on diabetes, angiogenesis, neurovascular development, and most recently he's transitioned to be a bit of an immunologist and is looking at anti-tumor immunity and the role of neutrophils. Joe's published 272 peer-reviewed articles and topical reviews describing this work. He's been to present these findings at over 200 national and international conferences and seminars. And of course, as you'll hear from today from some of the speakers, Joe's amassed a very large group of outstanding collaborators, trainees, and colleagues through this period. Beyond his research, Joe's excelled as an educator. He's devoted considerable time and effort to the teaching missions here at Yale, both in the medical school and the undergraduate Yale College course. He served as Director of Medical Education and Pathology for no less than 20 years. He was honored in 2001 by the very prestigious Shugai Award for Outstanding Mentorship and Scholarship by the American Association of Investigative Pathologists. There's only one of these awards given each year nationally, so to receive this out of the whole nation is quite an honor. And in his research laboratory, and you'll hear from some today, Joe has trained over 100 postdoctoral fellows, MD, PhD students, and undergraduate students. If this wasn't enough, he's also been an outstanding community citizen of Yale and the greater scientific community. He's been on multiple NIH study sections. I lost count when I was trying to figure this out. He's been on study sections for the American Heart Association. He served as an assistant or associate editors for the American Journal of Pathology, Laboratory Investigation, the FASEB Journal, and the Journal of Cellular Physiology and Angiogenesis. He's been on the scientific advisory boards of the Shriners Research Institute and the Genzyme Tissue Repair, Inc. He was one of the co-founders of Alexion Pharmaceuticals here in New Haven and has served on their advisory board for many years. And to top all this off, throughout all this, Joe has remained clinically active as a practicing pathologist and a member of the medical staff here at Yale New Haven Hospital. In his extracurricular affairs, Joe has, for 3 decades, been a student of the martial arts. He holds a 4th-degree black belt, is an international instructor in Taekwondo, and in fact used to practice this in our conference room in the evenings. And I wondered, Joe, about some of the furniture damage in that room, so that's that point. I think last and certainly not least, Joe and his wife Lucille have been very generous philanthropists. They made major donations to their alma mater in Indiana, the city of New Haven, and last year, as many of you know, established an endowed professorship in their name for experimental pathology here at Yale. So in so many ways, this symposium we're hosting today is a way of thanking you, Joe, and your wife, Lucille, for all that you've contributed over such a long time. So now it's time to sit back and enjoy the fruits of others that you had so much a big hand in helping to bring to fruition. So very good. So. Okay, on to the thing. Our first speaker, she's still here. She's a practicing physician who has, I understand, a sick patient. So if, Laura, you have to leave at any point, we will understand. But I hopefully not before the next 30 minutes. Our speaker is Professor Laura Ment, who is a professor of pediatrics and neurology here at Yale. She's also the Associate Dean of Admissions. Laura received as a graduate of both Brown University and Tufts University School of Medicine. She received her training in pediatrics at Massachusetts General Hospital. Ever since, certainly as long as I have known her, and I think since her early stages of her career, she's been particularly interested in neonatal brain injury in both preterm infants and some of the consequences of that, including intraventricular hemorrhage, perivascular white matter injury, seizures, and other such conditions. She has been the principal investigator on multiple grants here at Yale. I had the honor of sharing on such grants with Laura, and certainly Joe and Laura have had a long-term collaboration. She is, I think, as you may hear, I don't know exactly what Laura's going to be talking about today, but certainly my knowledge is they had worked together for many years to develop animal models of some of the clinical conditions that Laura was experiencing in the clinic. And this has had major impact on the care of such infants and certainly on understanding the microvascular niche and the way this has guided early brain development. So without further ado, I will turn the podium over to Laura. And I had changed computers. Got to do that too, I guess. Room, laptop. I'm getting some help in the back, I see. Get you going here. Here, you want to use this?
Sure.
Flip it on. That's the time.
All right.
All right, good.
Well, I'd like to thank Dr. Morrow and the organizers of this wonderful seminar for inviting me to speak. I met Dr. Madri in the hall in front of his lab in 1984. Bill Stewart, who's somewhere in the audience, sent me down to find somebody to help us with our research. And thanks to Joe, really our research was able to take off and continue over many years. So I'm a clinician, and I know that you're going to hear a lot of basic science later. But really, thanks to Joe, we were able to submit a grant, a multi-center grant, to study preterm infants, the prevention of intraventricular hemorrhage, and what happened to them over the years. So I'm going to tell you about imaging their brains. And I'm the person who gets to stand up here and talk. But really this work is in large part attributable to Todd Constable, who couldn't be with us today, but who's the head of the MR Research Center. Betty Vore is our long-term collaborator at Brown, and then the other people are part of Dustin, part of Todd's lab. So preterm birth is really a global pediatric public health problem. In the United States each year, we have 4 million deliveries of healthy babies, but almost 12% of them are born preterm. And if you're born preterm, it depends on how early you are, but as many as 50% of them have significant language disorders. So this is a major problem when they come to school and when they grow up. Unfortunately, here at Yale, we have the opportunity to use sophisticated MRI strategies, and we've used these strategies since 1995 to look at the preemies in all of our studies. Actually, in 1995, something happened to our group that will never happen to me again, and that is really a rarity for NIH. But they called us up and they asked us if we could image the preemies in our indomethacin cohort. The indomethacin cohort was 505 babies enrolled at Maine, Brown, and Yale between 1989 and 1992. They weighed between 600 and 1250 grams at birth, and we followed them for over 23 years. So this was a trial really based on the work that Joe had helped us do in the early 80s, looking at preventing intraventricular hemorrhage. We took it to pilot trials here. We moved it to a multi-center trial, and because we had a large, interesting cohort and it was efficacious, we were able to follow them for many years. So in 1995 and published in 2000, we started our MRI studies on the survivors of the randomized indomethacin IVH prevention trial. This was our very first paper. It was done by a young man named Brad Peterson. He was a postdoc in the Child Study Center who had learned imaging at Mass General. And what it is a volumetric study of preterm brains compared to term control brains. And this is a statistical parametric map. Here's the left hemisphere, here's the right hemisphere, and where there's no difference between the preterm subjects and the term controls, it's Yale blue. So in the back and sort of in the front. Where there's a big difference, it's red. And you can see that this is the temporal region, the parietal language regions, right where the preemies talk. Overall, the brain was 6% smaller in the preemies compared to the term controls, but in these regions, it was as much as 30% smaller, suggesting that there was actually a reason that we could explore in the preemies for why they had so much trouble with language. So this is a study that was done by a Yale medical student. I'm going to thank all the Yale medical students who have worked on this project across the years and the residents. This is Kate Mullen. She's becoming a neuroradiologist in Boston right now. She looked at our preemies when they became 16 years old and gender-matched term controls. Kate did diffusion tensor imaging, which is the first thing that our MRI research center was doing, and she wanted to look at the language pathways. So the dorsal pathway, here in blue, subserves phonology, and it's just supposed to be your left arcuate. The ventral pathway, in red, subserves semantics, and that's bilateral uncinate fasciculi, right here. So for those of you who don't come to pediatric neurology clinic every day, phonology is how you break down a word into the component parts. So when you come to my clinic and I make you say popopodiddle, that's phonology, okay? So what Kate showed was that unlike the term controls, the preemies were using both hemispheres at age 16 for phonology. So either they hadn't pruned what was going on in the right hemisphere or they had an alternative pathway. So in the next 20 minutes, because John has told me I can have 25 total, I'd like to suggest that functional studies suggest the engagement of alternative pathways in preterm-born subjects. Neonatal studies demonstrate alterations in functional organization for language, and that language systems are actually altered prior to birth in children born prematurely. So what we do in Todd's lab is functional connectivity. And Todd made this slide for me, so I'll make sure that I show you everything. So these are brain regions that Todd has randomly assigned. If two regions are functionally connected, like the green region and the brown region, then they're oscillating at the same frequency. And we say they're functionally connected. If they're oscillating at different frequencies, they are not functionally connected. So there's no, in pathology, neuropathology, none of you all could dissect these out and show where they're connected. This is purely based on physics. All right, so our first hypothesis was that preterm birth would alter functional connectivity for language. And this is a study that was done by Yesner Gasso. Yesner was a resident and then a neonatology fellow when she did the study. She's now on faculty. She took 54 of our preterm subjects and 24 of our term controls at age 8 years. They had absolutely no difference in their language testing scores, and they had no evidence for IVH, no PVL, no brain injury. And she gave them a passive listening task. They wore headphones. It was actually the ugly duckling mixed up several different ways. And she picked a reference region to do seed connectivity. And then she did a voxel-wise evaluation of 9 language regions to look for connectivity to Wernicke's, which is your receptive language area. And what she showed, here's the Wernicke seed, Brodmann's area 22, that the preemies were far more connected across the hemispheres, both to Brodmann's area 40 and Brodmann's area 44, 45. So these are more frontal language regions compared to the term controls. They were also more tightly connected in the left hemisphere to Brodmann's 40. So for the first time showing that using functional imaging, the preemies were using more regions to get to the same testing score. Or as my husband Duncan says, use the brain you have. And so I think they were using the brain they had to get there. When Yesner published that study, we didn't know how these correlated exactly with the testing scores. This is Eliza Myers. Eliza was another neonatology fellow. She's now on the faculty at Einstein in New York. Eliza went back and took the same children at age 16, gave them a different task, and she was able to show that the more the connectivity across the hemisphere from left BA 22 to right BA 40, the lower the testing score. So if you were using that right hemisphere connectivity, it was because you needed it to get to where you were. And so we concluded at this point that the preterms could have the same scores but different connections. Were they using auxiliary pathways, or did preterm birth functionally alter what was going on in the organization of the developing brain? And so our next hypothesis was that voxel-based resting state functional MRI would show differences in functional organization of the brain at age 16 years. So in the previous study, the kids were wearing headphones, we were pumping in a study, they weren't doing anything else, we were recording their functional connectivity. In these studies, the children just lie in the magnet on Friday afternoons at 4 o'clock, and we do what we call resting state functional connectivity. We also make sure that they're awake, okay, because 4 o'clock on a Friday afternoon is a lethal time for teenagers. But we looked in this study at cerebral lateralization. So most people think that cerebral lateralization is a defining characteristic of the human cortex. And structural asymmetries for language develop during the 3rd trimester, and these asymmetries and lateralization correlate with language scores in children and in adults with neurologic problems. And this analysis was done by Dustin Shinost. He's the newest assistant professor over in MR imaging, and this is how one calculates connectivity lateralization. So in the first hemisphere, let's say that this is your right hemisphere, we put a seed and we look where that seed is connected in the entire hemisphere. And then we look in the contralateral hemisphere, and if you subtract the contralateral connections from the ipsilateral connections, you get what we call connectivity lateralization. And each map is normalized prior to this subtraction to determine laterality, and all subjects are scaled equally. So what Dustin showed is that the preterm subjects had less lateralization in left Wernicke's region and right BA 39 and 40 at age 16 years. And you can see the areas in blue where there is less lateralization in the preterms compared to the term controls. And here are just the individual maps. Here's just a graph showing that the terms are lateralized, the preterms are not. But what does this mean? Because if we're going to do all this functional imaging, we need to make sure that it has some real-world application. And in fact, if you're more lateralized in left BA 40, these are the preemies, the testing scores are better. If you're less lateralized, the testing scores are worse. If you're lateralized over on the right side, much poorer. So you need to be lateralized in your left hemisphere for language to do well at school age. But what about babies? Are they born with this? Are the preemies born with this problem? Or is it something we do in the nursery or some failure of early intervention? So what about the preemies? So this is my favorite study. It was done in Stockholm and Seattle. This was not part of our own work. This is Hugo Lagerkrantz. Hugo's been here lecturing. This is 80 newborns, 40 in Stockholm, 40 in Seattle. They were studied when they were 33 hours old. And they had this really cool way of assessing whether they were listening or not. They had a binky that was hooked up to a manometer. And the more they sucked, the more pressure waves there were. The less they sucked, no waves. And they listened to an audio of their mother speaking in their native language or their mother speaking in a non-native language. So it was always the mother's voice because fetuses hear mother's voice, but either Swedish or English, okay? And it was assessed by the number of sucks. And, what? This is a very cool study. And in fact, it was highly significant that the babies were bored by their mother's own language. But when the Swedish babies heard English, suck, suck, suck. When the English the babies in Seattle heard Swedish, they sucked like crazy. So babies recognize novel sounds and voices. Sue Kwan, who was a fellow in neonatology and now is also on the faculty here at Yale, hypothesized that for our preemies, our very low birth weight preemies, less than 27 weeks of gestation, so 24 to 27 weeks of gestation, mean birth weight 550 grams, that functional MRI would demonstrate alterations in cerebral lateralization when they were due to be born. So, for instance, we saw a baby in clinic this morning. She was born on November 3rd. She was due to be born on March 4th. Okay, so that's like one of my babies. And Sue showed, using resting state functional connectivity, that the preemies didn't lateralize for language. So if they had lateralized, this is the left hemisphere, this would be bright red and yellow. But it's not, because it's a subtraction, so that they're much lower than the term controls, so it's blue and purple. So they do not lateralize for language. And in fact, if we put a seed in Wernicke's right here, this green mark, these are the term controls, they cross right over to the opposite hemisphere. So they have cross hemisphere, that's how your hemispheres start to talk to each other. So the term controls, right after they're born, we take them down from the well-born nursery. They have cross-hemisphere lateralization. The preemies, not so much, and actually not much at all. So here at term equivalent age, when they're due to be born, there's very little, if any, crosstalk between the hemispheres, suggesting that something that you all can figure out for me is going on at the molecular level. I got a little anxious when John told me that that was only 25 minutes, so I pulled the slide that showed if you put a seed over here, they also don't cross the other way, okay? But the good news is that you were all going to ask me is, do they cross anywhere? And the answer is yes, they cross in the motor cortex. So here's a seed in the left motor cortex, term controls cross right over to the right hemisphere. Here's a seed for the preemies. Again, they cross. So they do have the potential to cross in different functions, just not in language. So we concluded at that point that there were alterations in organization of language systems in preterm brain, and that we could detect them at term equivalent age. But how to best examine these findings? We thought long and hard, what is the control for a preemie? Joe thinks about this in the lab. What is the control for the preemie mouse? So we thought about it a long time, and we decided that a typically developing fetus was the control for a preemie. And these are some of our fetal images. Okay, Dustin made these fancy slides for me. So we knew that here's the term lateralizing at term age. Here's the preemies, that they're not lateralizing too well at term equivalent. And there they are even earlier. So preemies have a problem with lateralization. But one of our collaborators, Mariah Thomason, who was at Wayne State and who's now in Berkeley and Stanford, was looking at seed-based connectivity. And Mariah looked at fetuses between 22 weeks and 40 weeks. She put a seed in Broca's and she showed that it crossed the hemisphere. She put a seed in Wernicke's and showed that it crossed the hemisphere. So we thought that we would try to do functional imaging on fetuses. And I'm going to show you the data on 10 typically developing fetuses. Our fetuses, really for the first time, had longitudinal images. We scanned them at 30 to 32 weeks. We brought them back at 34 to 36 weeks. And then after they were born, we whisked them down from the well baby nursery and popped them in the scanner and scanned them again. This was over, for those of you who have been there, in the pediatric magnet. Looks like a beach. They have beach chairs for the moms to sit in. And we did 4 5-minute runs of resting state functional connectivity. And this is really thanks to Sarah Cross. Sarah is a high-risk obstetrician whom unfortunately we've just lost to Minneapolis. And this is what, I hope you all can see that in the back, this is what a fetal functional imaging scan looks like. So for those of you who are physicists, there is a lot of motion in there. I can show you that the eyeballs are, see the eyeballs right up there? Okay, so this is an axial cut of this fetus. So the mom is breathing, the fetus is breathing, the aorta is beating, and the placenta is bleeding. So that's a lot of motion. But thank goodness for Dustin Shinos, the young man whose picture I showed you. It took him 6 months, but he was able to get rid of all that motion. And so and he comes up with functional images that look very close to this. This is, he tells me, super perfect. And if you look over here, you're going to see the the fetus's eyeballs come. See the eyes? This is an axial cut. See the hemispheres? This is a 30-week brain, so it's very smooth. You can see it come right up to the convexities. So with that kind of imaging, which is really a huge tribute to Dustin because a lot of people have been working this all over the world, you were able to do fetal functional imaging. Because when it's moving like crazy, who knows where the signal is? And so the first study that we did was look to see if they were lateralized. And in fact, already at 30 to 32 weeks, the fetuses are lateralized for language. See? And they're pruning down their laterals, their connections at 34 to 36 weeks. So this language region, which we thought came much later, is in fact here in the fetuses, and probably here even before we looked. And so we were very fortunate that Mariah, who was still at Wayne State, but who sends us all her data to analyze, and us being Dustin, with me just being the supervisor, sent us data on 32 women with appropriate for gestational age fetuses. They had had fetal resting state functional connectivity, a single scan, at a mean gestation of 29 weeks, so right at the beginning of the 3rd trimester. 14 of these pregnancies ended in preterm delivery. And the preterm delivery, the mean age was 32 weeks with a range of 34 to 35 weeks. And 18 of them went on to be term deliveries. And the most interesting thing that we discovered in these data is that you can see the alterations in language systems in those fetuses who are going to be born prematurely. So if you can, here's the fetal functional imaging, looking at bold signal in the babies, the fetuses who were born at term. You can see the language regions here. Here's the babies who are going to be born preterm. No bold signal in the language regions, either in the temporal regions or in the frontal. And here's the area in Wernicke's region of the highest significant difference. And here it is in neurologic presentation. So the left is on your left in Mariah's scan here. And you can see this region in the left temporal differentiates the fetuses who are going to be born preterm compared to the ones who are born at term. And in fact, if you put a seed there and see where it connects across the hemisphere, you can actually predict which babies are going to be born early. So here's the connectivity on the y-axis, and here's their gestational age at birth. So if you have aberrant connectivity as a fetus, these data suggest that you'll be born early. So this is Joe's next job. So in conclusion, I hope I've convinced you quickly that there's altered connectivity for language in the developing preterm brain, that it's lasting and predictive of outcome, and that in fact, preliminary data suggests that it's present during the late second and third trimesters of gestation in fetuses that are born preterm. And oops, so why did that not go? No, we lost Joe's slide.
Joe took it out.
No, he wasn't near my computer. Oh. Oh. All right, hang on. All right. When I first met Joe, he showed me his favorite slide, which is of this bridge. What bridge is this, Joe? This is the Verrazano-Narrow Bridge. And Joe likes this picture of it not being connected. And he felt that our work was just beginning, that we weren't connected, but that if we worked hard enough, we would eventually be connected. So Joe's a person to whom I have gone many, many, many times since 1984. He always gives wise advice. He provides the basic science upon which our clinical work has been able to be funded across the years, and he has my everlasting gratitude. So thank you.
Time for a couple questions, if there is some.
Can you predict intracerebral hemorrhages by this method?
We haven't tried that yet, but that would be a very good question. For those of you who don't study IVH, we believe that IVH is not an in utero event unless it's a big fetal hemorrhage with a known vascular problem. It would be interesting to see if there are differences in the germinal matrix region in the children who are born preterm. So we could look retrospectively, maybe.
With cattle and sheep,
Yes.
we had a small cadre of cord blood, venous cord blood from kids at birth, trainees. And when we looked for BDNF, VEGF, and SDF1, we could predict which kids were going to get a hemorrhage. The small study never followed up on it. But there's a difference then in expression level and a variety of growth factors.
Now you have to repeat that question for that lecture.
Okay. Okay. Yes.
Here's sort of the obvious question, but what do you think is causing this change in wiring before the child? I mean, what kind of stressor or something genetically different?
So I think that's why I said Joe can't, the bridge isn't done. I didn't show the second slide. I don't know. I think that all of you in this room need to help answer that question. Because we thought in the preemies, for any of you who've been in our newborn special care unit, they get hypoxic, they get hypotensive, they get hypoglycemic, they get periventricular leukomalacia. But this is really the first paper, and it was just published, that suggests that, in fact, you can see this before they're born. And so maybe there's a genetic predisposition. Maybe there's some factor that results in preterm delivery and altered wiring, because, of course, there's a huge overlap in the genes that cause preterm birth and are related to brain development. There's just an enormous overlap. So I think for the next generation of scientists, this is really the hot question. Okay. Thank you.
What about low-weight babies that are born at term?
Intrauterine growth retardation, yes. So the people in Zurich and Geneva have been studying IUGR for many, many years. So intrauterine growth retardation is actually a symptom and not a diagnosis because there are many, many causes of it. But if you just take, and these are babies who weigh less than the 10th percentile for growth at birth, if you take a whole cohort, they have big aberrations in wiring. But many of these babies are IUGR because of infection, because of problems with the placenta, because of the mother's hypertensive. So there are many, many factors in there. But yes, they have. And they haven't had many functional imaging studies, but even on DTI, they're wired differently. So some axonal guidance molecule is not right. Okay. Thank you.
So our next speaker is Dita Gratzinger, who's a MD, PhD hematopathologist from Stanford. Just a few words about Dita. Dita was one of the trainees in Joe's lab. She was originally, did her undergraduate work, where did you, in Stanford, right?
Cal.
Oh, Berkeley.
Bears.
Ooh, sorry, Mina. And then was an MD, PhD student here at Yale, where she worked on her thesis in Joe's laboratory. Subsequently, she returned to California at Stanford, completed her pathology residency in AP and hematopathology fellowship there, and joined the faculty there at Stanford, where she is today. She has, well, you can read about it. It's in your thing. I won't take more time.
Yeah.
Has an interest, an unusual interest, I would say, as a hematopathologist in the vascular niche, or the niche that the bone marrow resides in. So you can put that on. I'm going to turn over to you, and I'm going to start the timer. And whoops, stop the timer, because we got to fix this, don't
Pressure.
we? Pressure. Where's the keyboard? Stop that.
So is this picking me up?
Yeah, I think so. Which one's yours? Vascular at the core.
Vascular at the
That's it.
core.
There you go. Oh. Bingo.
Yeah.
Yeah.
So I came to New Haven in 1996, and just a couple of years later, I was in the MD PhD program. I had the good fortune to rotate through Joe's lab and sort of fall in love with what he was studying and the just the excitement in the lab. And what I've done in this talk is try to show how that time in Joe's lab has really inspired me going forward into what I do now. So, as you can see, I'm at Stanford University now, but I'm class of Madri 2002. Okay. And as you can see, I was really happy to be in that lab, sorry. Yeah, and I can see a couple of the reasons for the excitement in that lab here. Of course, Joe, who was just always just happy to be there, excited, made everything possible for us. But also the other thing that made that lab so wonderful was just the variety of wonderful people in there. And I see Anna and Sandy in the audience here. And Sandy was just amazing in terms of providing support and like a huge amount of knowledge and technical support for everyone. Anna has gone on to get a JD and like work in technology. Sorry, she's going to be shy, but I mean, these are the sort of people that Joe's lab produced. It's amazing. Lara is now in Switzerland doing basic research. So there are pediatricians in here. Josephine Enciso is a neonatologist also at UCLA now. I mean, just the variety of people that Joe's lab had then and has produced is amazing and is really a testament to his mentorship. Okay, so here are a couple of the things that got me excited in Joe's lab way back when. So of course, back when I was there, Joe's lab was mostly concentrating on CD31 or PCAM1, and we were looking a lot at endothelial cells. And one of the things I did was wound a whole lot of cell cultures, right? Just grow these HUVEX or bovine aortic endothelial cells in these plates and then just scrape them and watch them grow back in and try to figure out why it was that the ones that were missing CD31 grew back differently. And we figured out that some of this had to do with the ITIM, sorry, it's been a few years, the ITIM, the immunoreceptor tyrosine-based inhibitory motif, and the SHP2 phosphatase that sticks to it. And some of the things that caught my eye at that time was the patterns, the beauty of the changes in the cell morphology and the patterns, which is what led me to go on into pathology. So you can see here how SHP2 in the confluent cells is really sort of at these beautiful focal areas and co-located with PCAM1. And in the migrating cells, it really redistributes. Okay, there we are again. Did I go backwards? I must have gone backwards. And then, yeah, I've got it now. We're going to go forward in time. And then the idea that, you know, just looking at these cells, I had noticed these changes in morphology, right? So you can see that the PCAM knockout cells have these sort of attenuated, sharp edges, whereas the control cells did not. They had this nice cobblestone pattern, which turned out to be associated with changes in cytoskeletal architecture and small row GTPases. So that was so cool, being able to go from sort of morphology to the mechanism of how these cells were moving. And I'm doing it again, sorry. I guess I can't use that. So I wanted to say thanks for everything, Joe. We had a great time in lab and out of it. Sandy. So there's Sandy again, and Anna with a black Egyptian. We're kind of embarrassing them. Okay, so here we are. So I'm going to talk about the aspects of my translational research that have to do somewhat with vasculature. I do mostly clinical work. I'm a hematopathologist. I run our fellowship at Stanford, which has 4 hematopathology fellows, but I do find time for translational work as well, which is what keeps me excited and going. So I concentrate a lot on myelodysplastic syndromes, or MDS, which is a clonal bone marrow failure disorder affecting 1 or more hematopoietic lineages. MDS is associated with ineffective hematopoiesis, which results in anemia, thrombocytopenia, et cetera. And these patients, it's not an easy sort of diagnosis to live with, because a lot of them are transfusion dependent, they get iron overloaded, they're susceptible to infections. Many of them die because of these cytopenias and the iron overload, and a subset also can develop acute leukemia. Really, the only way to cure MDS is with a stem cell transplant, but unfortunately most patients who get MDS are in their late 60s, 70s, and on, so they may not be good candidates for stem cell transplant. And it turns out that, you know, when we look at the bone marrow, we think about trilineage hematopoiesis. But there's a lot more to the bone marrow than just the hematopoietic elements. There's the whole infrastructure of the bone marrow, the microarchitecture. And back in 2010, I'm not going to attempt to pronounce this right, Reimachers et al. Published this paper about how messing basically with a subset of the mesenchymal stromal cells could induce myelodysplastic syndrome in mice. So just by changing the makeup of the mesenchymal stem cell, which is thought to contribute to both mesenchymal stromal cells, osteoblasts, and to the fat of the bone marrow, they could cause a MDS-like progression in mice. But it turns out that when we try to diagnose MDS and when the hematologist oncologists prognosticate on MDS and decide what therapies to give to MDS patients, they're not looking at the microenvironment at all. We look under the microscope and decide whether there's morphologic dysplasia, so whether the erythroid, myeloid, and megakaryocytic elements are malformed morphologically. We count the immature cells, or blasts. We look for cytogenetic abnormalities. And then for prognosis, this also takes into account cytopenias. So really, except to some degree fibrosis, the marrow microenvironment is not currently evaluated during clinical diagnosis and prognostication. So what we thought was that there's something here that could really add to the diagnosis and the understanding of human MDS. So just to bring home the idea that the bone marrow is not some sort of homogenate of developing marrow elements, there's a real architecture and there are domains to the bone marrow, right? So here you have some trabecular bone, and we have these little ink dot erythroid colonies. And here's one closer up with its central macrophage containing some iron. And it's hugging this sinusoid, which is sort of ectatic and full of erythroid cells. So it's in intimate contact with that element of the marrow vasculature. The myeloids, on the other hand, you can see these slightly pink-looking cells that are lined up along the trabecular bone, and they also form cuffs around a different component of the marrow vasculature, which is the capillaries. And lastly, the megakaryocytes, which actually are also in intimate contact with sinusoids, and in fact, they sort of wave their little feet into the breeze and bud their platelets off into that sinusoidal vasculature. And incidentally, I went and looked because I thought I remembered this. But Joe, this didn't involve me at all. This was after my time. But Joe found that in that CD31 knockout model that these mice failed to localize their megakaryocytes to that sinusoidal niche, really, where they need to be in order to properly bud off platelets to the bone marrow. And I didn't read this in detail. Joe, were they thrombocytopenic, the mice?
No, they weren't. There was an increase in megas and spleen.
Oh, okay, so they made up for it. They compensated. But really cool nevertheless. So I've talked to you about where the maturing hematopoietic elements are, and then I want to speak to you of the other elements of the marrow, right? So we have bone, stroma, and resident mature hematolymphoid cells. Okay, so here's our normal trabecular bone. We have this beautiful lamellar bone that's laid down bit by bit and ossified. We have the unossified osteoid seam, which is made up of type 1 collagen. We have our osteoblasts and osteocytes. And I want to sort of emphasize the fact that in adult humans, older adults who are the ones who get MDS and a lot of the other myeloid neoplasms, we're talking about flat bones for the most part, where hematopoiesis happens. In mice, most of these mice models, you're taking a very young mouse and you're sectioning their femur, so you're talking about a long bone, which is totally different. Okay, so adult human iliac crest contains these interanastomosing trabecular meshworks, and they're about 0.6 or 0.7 millimeters apart with a plate thickness of about 0.1. So you have this huge surface area of trabecular bone where most adult or older adult hematopoiesis happens. Okay, moving on to the stroma, so adipocytes, vessels, reticular cells. So just to show, and we, or at least diagnostic hematopathologists know this, but adipocytes are a large component and an increasing component of human marrow. As we age and we lose bone mass, we gain fat cells in the marrow. So by the time we're in our 60s or 70s and at the prime age to develop MDS, we actually have more fat volume than hematopoietic volume in the marrow. Okay, and this is in stark contrast. Again, this is a mouse femur. The mouse biologists here probably recognize it, where you have this cortical bone, very little trabecular bone, very little fat, and even the microarchitecture of the vessels is different, right? Because you have these nice longitudinal capillaries, which is different from the branching microvasculature in human trabecular bone. Okay, so blood vessels are an organizing principle of the marrow. I already showed you how they're an organizing principle of hematopoiesis. So we have two major types of vessels in the marrow, these small diameter capillaries, and you can recognize these on H&E because they have a round contour with the endothelial nuclei bulging in. They're lined by pericytes or vascular muscle, and they're cuffed by plasma cells or maturing myeloids. And then you have the other aspect, which is the thin-walled sinusoids, which are discontinuous and gaping, and they don't have that pericyte layer. And they have erythroids and megakaryocytes next to them. And lastly, you have various resident mature hematolymphoid cells, but macrophages are particularly prominent. And this is just a picture. So here's an immunohistochemical stain with CD163. And you can see your nice normal trilineage hematopoiesis and lots of macrophages in the background. They tend to be these attenuated bipolar cells. Sometimes they have more extensions. And I also did some immunofluorescence here, so you can see erythroid colonies with that central macrophage, which we expect to be there, but notice that there are macrophages outside of erythroid colonies as well. So that's normal. People can get themselves in trouble when they suspect HLH and they do a CD163 and they don't normally do it and they go, too many macrophages. No, this is normal. Okay. Mesenchymal stromal cells, they support the self-renewing proliferation of CD34 positive hematopoietic progenitors and are part of the so-called stem cell niche. But most of what has been known about these has been from mouse models or from purified cells. So what I did was to try to go look for these guys in intact human marrow from patients with MDS and comparable patients with cytopenias. So I tested out a number of markers and settled on CD271 is working the best and most specifically in human marrow. I'm going to show you that. This is what I just said. So we went ahead and characterized these using IHC, double immunofluorescence, and some confocal as well as wide field microscopy, and then looked at larger cohorts using a tissue microarray platform and quantitating things using slide scanning or photography and image analysis. So I maintained that quantitative bent that I learned in your lab. Okay, this is what a tissue microarray is for those who aren't familiar. So when specimens come to the diagnostic pathology laboratory, they come in formalin, they get embedded in wax basically, like this, and then we cut thin sections of them and put them on a slide to look at. So what we can do is take a biopsy of the biopsy with like a 1 millimeter hollow core needle and put them in a new paraffin block and then cut slides, cut sections and then look at them. So this is, you can see this is MDS because this is a dysplastic megakaryocyte here in one of these actual tissue microarrays. Okay. So I've told you about the two different types of microvascular beds in the marrow. In mouse, there was a publication that said that VEGFR3 can distinguish between this. It's different in humans. And what we showed was that you can pick out the capillaries very distinctively with nestin, and the sinusoids fairly distinctively with CD105. So then having those distinctive markers allowed us to quantitate those. Whoops. Oh, sorry, I talk about that later. I've mixed up the timeline here to make a more coherent story, but I forgot I had done it. Sorry about that. So we also then found that CD34 hematopoietic progenitors or stem cells are rarely directly in contact with that sinusoidal endothelium. So you can see here a CD34 positive hematopoietic progenitor cell. The CD34 is on these little lipid rafts, so that's why it looks blotchy. And here's the sinusoidal endothelium co-expressing CXCL12. So that's part of the niche there. Then we have those mesenchymal stromal cells I told you about. And you look at the bone marrow and you have no idea how many other elements are in there. The entire bone marrow is full of these beautifully, delicately arborizing mesenchymal stromal cells. And they're positive for both CD271 and ALP. When I say full of, I really mean it. They're in there forming like a meshwork that you really can't see on H&E. Right? So they're lining the trabecular bone, they're lining the sinusoids. They're in all the places where we expect the niche to be. Okay. And they're in intimate contact with the microvasculature. And what this looks like is different for sinusoids and capillaries. So in sinusoids, they're right up against the endothelium. In capillaries, there's a layer of parasites in between. Okay. So you can think that if you're a progenitor cell and want to get out into the vasculature, you're going to be blocked by these CD271 positive MSC, except in a few very focal areas that could be entryways, and only in the sinusoidal vasculature. And it turns out that the CD34 positive hematopoietic progenitors are in intimate contact, and I mean embraced by CD271 MSCs. And I didn't have a good way to do this by image analysis, so I sat and counted what percentage of CD34 positive progenitors are in direct intimate contact with MSCs. And it turns out it's essentially all of them, whether in MDS or in benign marrow. So what we come to is this vasculocentric model of benign marrow, where we have this differentiated vascular bed lined by CD271 positive mesenchymal stromal cells that also branch out into the perivascular space. And we have CD34 positive hematopoietic progenitor and stem cells associated with it. And in some cases, they can be in direct contact just through a very thin attenuated endothelial cell wall with the outflow. Okay. So the next step, since I'm a diagnostic hematopathologist, was to try to see if there's a change, and we had an indication of this, whether there's a change in the density of CD271 positive MSCs in MDS. So for this, we had control cytopenic patients and MDS patients, and we just went ahead and quantitated the density of CD271 using these tissue microarrays associated with clinical outcomes. So this is what that image analysis looks like. You can get a denominator by just excluding the fat, and the numerator is going to be, so the red is actually the immunohistochemical stain, and the yellow is the object identification. So we've outlined all these CD271 positive MSCs very cleanly and can quantitate them. So this is an example of low and high mesenchymal stromal cell density in bone marrow. And in fact, we did find that there's an increase in the density of MSCs in higher grade MDS, meaning your refractory anemias with excess blasts. I guess now it's MDS with excess blasts. They keep changing the terminology on us. Okay. And this was actually independently predictive of survival, independent of the prognostic factors that our hematologist oncology colleagues use, like IPSSR, transfusion history, etc. Okay. So now we have a vascular-centric model of the MDS marrow, right? So now instead of just having a few areas where these CD30 positive hematopoietic progenitor cells are touching sort of endothelium, which is where the CXCL12 is also expressed, we have this big meshwork of CD271 positive MSCs that are in association with the hematopoietic progenitors, and CXCL12 is also turned on in these, which is that I didn't have time to show you. Okay. The other thing we found was that there was a selective expansion of the sinusoidal compartment in MDS using this differential staining for Nestin-positive capillary microvessels and CD105 positive sinusoidal microvessels. So I probably should go ahead and update this and put in some more sinusoids as well. Okay. And then I also told you at the very beginning that there's transfusion dependence and iron overload are a big problem in terms of morbidity and mortality in MDS. So we also looked at macrophages, the iron content of the marrow, and heme oxygenase 1 expression within macrophages in MDS and benign cytopenias. And it turns out that CD163 positive macrophages contain most of the cytoplasmic HO1 in the marrow. There had been talk about this being within other components of the niche, but it's really, we can say quantitatively that they're mostly in macrophages. And then what we can do is quantitate the percent of the macrophages that are HO1 positive by doing sort of a two-step object identification and then associating those objects. So we come out with this false color image that shows HO1 positive and HO1 negative macrophages. So it's sort of like an in situ flow. Okay, so by using that, I was able to show that a few interesting things about the state of iron processing or handling in MDS marrow. First of all, there's iron overload in MDS marrow independent of transfusion status before you even start. That I didn't show you here. And then it turns out that in benign cytopenias, when they're transfused, there's not really an association with increased HO1 expression. But in MDS, you transfuse those patients and their macrophages get upset and start overexpressing HO1. So there's something very different in the way that MDS marrow is able to handle and respond to iron. So that's really interesting, I think. And that's all done with just paraffin-embedded tissue. And lastly, that there was actually poor survival among these HO1 high MDS patients. So having these macrophages with upregulated HO1 was somehow associated with poor prognosis, independent of IPSSR, independent of transfusion history. Okay, so I'd like to say, for all the wonderful work that everyone here, many people here are doing in the basic science lab, it's really still important to bring it back to the human tissues. And there's an amazing amount that we can learn from those intact human tissues, and we can do it pretty rigorously. So we pathologists were doing clinical work have much to contribute to the understanding of health and disease. And I wanted to acknowledge some of my collaborators. I've had a couple of trainees, and mostly Joe Madri for his mentorship, his modeling of how to be a mentor, now that I'm getting to try that out a little bit, and his infectious love of the vasculature. Well, it helps to have the time right here.
So these patients typically have sequential biopsies?
No, this is all these are diagnostic biopsies before they've been treated.
No, I said that they have biopsies.
Yeah, often there are. I haven't looked at that. Haven't had yeah. But yes, go ahead. What would you do if you could look?
Well, the question is, to what extent the stromal abnormalities, to what extent do they precede the other abnormalities?
Right. Well, I can say they precede therapy, but it would be really interesting to see, does some of that correct with the cytidine, for example? I don't have the answer to that. Yes?
For these cases in which you've looked at the outcomes, is it possible, I know that this was probably done before people were doing extra sequencing, but
Yeah, I don't have the mutation status on these. It took me a year. Yeah. Sorry, is it possible to get like the next-gen sequencing results on some of these? And that would be fascinating, but unfortunately, I put together these cohorts several years ago, so I don't have that information on them. The field is moving so fast. So it's something I want to look at going forward, but it can't be with these cohorts. Yes?
What is the source of the adipocytes accumulating in the bone marrow with age?
So the thought is that they differentiated from the mesenchymal stem cells, actually.
Is that causative for MDS syndromes? Or
Well, if it is, then we're all headed for MDS, right? Because it happens in everyone.
I guess not causative, but is it a contributor?
And that's a really good question, and it's entirely possible that the fat cells themselves are the source of some chemokines that are dysregulated, but I don't have the answer to that. Yes?
sorry, so you may have said this and I missed it, but to sort of follow up on the question, if the MSCs are kind of giving rise to the adipocytes, and the increased number of adipocytes in older age, are you losing MSCs too?
I'm not sure of the answer to that question. There's basic research that addresses those sorts of things, and there are changes in the proportion of fat cells versus other types of cells that MSCs give rise to with age, and all that has been done in culture. But that's not my data, so I'm not as familiar with it. Yes, sir?
You can push the button and then it stops it.
Ooh, thank you.
Any information on metakaryocytic migration from the endosteal niche to the vascular niche as far as the mesenchymal stem cell interactions?
They look like little guide wires, kind of like in the cerebellum when neurons migrate. It looks like it's ripe for that sort of thing, and that's the kind of question you can formulate based on looking at the architecture of the actual tissue, but I don't have the answer to it.
In MDS, does the difference of organization and composition of the matrix affect the MDS cell network?
I bet it does. I don't have the answer, though. Yeah.
What comes first?
The chicken.
One last question for you. Are they, in the MDS syndrome, those cells are presumably, we think of as partially transformed or labeled be transformed or something like that?
Yeah, they carry a bunch of
Are
mutations.
they the ones that are driving this reaction, or is the reaction driving?
It's probably a back and forth dance, right? As a lot of these things are. And there are subsequent publications, for example, from Raymond, that indicates that there's an inflammasome type of response that's driving, changes in the hematopoietic precursors. Thank you.
So our next speaker is Olivier Kocher, who's an associate professor at the Harvard Medical School and the Beth Israel Hospital. He received his MD and PhD degrees in biology from the University of Geneva in Geneva, Switzerland. And then migrated here and worked with Joe and became a postdoctoral fellow in Joe's lab for a few years. And then after that, completed residency training in pathology at BI Deaconess in Boston, and joined the faculty there where he is today. As I think he'll tell you about today, if I know, Olivier, amongst other good things that he's done, he discovered a protein that is named PDZK1, which turns out to be a large scaffolding protein involved in a control of a number of membrane surface receptors. And I think Al won't say more because he's probably going to tell us more about that today, right? Very good. Here, you want to put this on? And I'll try to get this working. And which one are you?
Yep.
That one? That's it, okay.
Well, so it's really an honor to be here today.
Here's a pointer, and that will advance it too, and the pointer's green if you need it.
I was here in '87, so Joe's lab was still pretty small at the time, and I was coming straight from Geneva, and it was quite a shock to arrive here. In fact, I had a very, very young family, and we'd chosen New Haven as a small, safe city. And just before I arrived, somebody told me it was not really the case. But anyway, I was very happy to be here. And what I have to say is that in Geneva, I learned how to work, how to do experiments. But in Joe's lab, and I'm very grateful, I learned to think better and to think how to ask scientific questions, and that was really important. As I said, we were a pretty small group, and we ended up all doing pretty well after being in Joe's lab. And one of us became an investment banker in Geneva, and I was I thought that was unfair because I was supposed to be the investment banker in Geneva. So anyway, so what I want to talk about today is a project we've been working on for probably the past 12 years, as we discovered a new protein, what is that here? That we named PDZK1, and that relates to the expression of the HDL receptor, the scavenger receptor class B type 1, which had been discovered earlier by Monty Krieger as the HDL receptor by excellence. What I want to say a little bit about the HDL receptor and cholesterol transport is what is particular about HDL is that it's supposed to be the good cholesterol. And the reason why it's the good cholesterol is that it takes cholesterol from peripheral tissues, which could be atherosclerotic plaque, and loads, the HDL is loaded with cholesterol and become highly enriched in cholesterol, and then interacts with the HDL receptor, that HDL receptor, scavenger receptor class B type 1, which is highly expressed in the liver and in steroidogenic tissues. And in fact, so it basically transfers cholesterol from the peripheral tissue to the liver and to steroidogenic tissue, where the cholesterol is used to synthesize hormones in a process called reverse cholesterol transport. And that process is supposed to be very beneficial to us, because it protects us from atherosclerosis and cardiovascular disease. The HDL receptor, or SRB1, is a very peculiar protein. It's kind of, if you have the cell membrane here, it's a horseshoe-shaped protein which has most of its body outside the cell and very short N and carboxy termini. And this carboxy termini turned out to be extremely important for us. So the way HDL-loaded, cholesterol-loaded particles interact with the SRB1 HDL receptor, it interacts through the ApoA1 apolipoprotein, which is the predominant apoprotein on the HDL particle, and through a passive mechanism is transferring cholesterol ester from the particle into the cell. Crystal structures have been solved for this molecules very close to the HDL receptor, showing that there is in fact a channel within the molecule where cholesterol molecules can be transferred. So it's very different from what happens with the LDL receptor. You remember the LDL receptor is the LDL particle binds to the receptor. The whole thing is ingested into the cells where it's dissociated. The cholesterol is separated, and the receptor is recycled in the membrane, which is that's very different from the HDL receptor, which stays on the membrane and where cholesterol is transferred by a mechanism called selective uptake. The reason we became interested in HDL receptor and cholesterol metabolism is through the discovery of PDZK1 protein. PDZK1 is a protein which contains 4 so-called PDZ domains. You see them here in color, okay? 1, 2, 3, 4. And these PDZ domains are present in many molecules, in about 150 proteins which are involved in cell surface receptor organization and also cell surface membrane protein activity. And the reason we became interested, they have been called according to 3 proteins, PSD95, DLG, and ZO1, which contain such PDZ domains. When you align PDZ domains together, and this is for PDZK1, you see that there are sequences that are very, very conserved. And one of these sequences is here. It can be NYGF, SYGF, GYGF, or GLGF, depending on some molecules. And this corresponds to an area of the PDZ domain, which is called carboxylate binding loop, where it binds, in fact, to the cell surface receptor, to that carboxy terminus of the cell surface receptor. That carboxy terminal of interacting with the PDZ domain is a very short domain. It contains, it's about the 3 last amino acid of the PDZ, of the receptor. And in fact, if you remove the last amino acid, which is here valine, you may as well cancel the interaction between the receptor and the PDZ domain. Why do these PDZ domain proteins have multiple PDZ domains? It's because they function as scaffolding proteins to organize complex cellular function, as here for INA-D in the eye of Drosophila. If you're missing one of these PDZ domains, it's likely that one of these interactions is going to be disturbed, and the functionality of all these receptors is going to be disturbed. So we became interested when we made a PDZK1 knockout mouse, and we discovered that doing a chemistry of the mouse, that the only thing abnormal was cholesterol. The cholesterol level basically in these mice was doubled in the PDZK1 knockout mice. And the reason why it was double is that SRB1, this HDL receptor, was markedly decreased in the liver, which the biggest organ containing SRB1, was markedly decreased by about 95%. And so the reverse cholesterol transport and the function of the HDL receptor was completely compromised. There was also a decrease in the small intestine, but not as much, and there was no difference in the adrenal gland or any other steroidogenic tissue. So basically, PDZK1 was an adapter for SRB1, but it was a tissue-specific adapter since in the liver it was really important, but it was not important in adrenal glands. When you look at the distribution of lipoproteins in the plasma of these mice, you see in normal mice, HDL is the predominant lipoprotein, okay? But in the PDZK1 knockout mouse, there is a much larger peak. And this peak, in fact, is larger, but also shifted towards the left. And it's a peak that's very similar to what you see in SRB1 knockout mice. So there were very big similarity between the 2 mice. So in addition, what we did then, to see if we could recover the function of SRB1 using transgene, we made several transgenic under an ApoE promoter to express these transgenes in the liver. And here, so the PDZK1, that SRB1 is almost absent in PDZK1 knockout, but when we add the transgene, we recover expression of SRB1. That's with the full-length protein. And we also decrease the cholesterol back to normal in the PDZK1 knockout containing the transgene here. And we also normalize the distribution of lipoprotein here. So PDZK1 is a tissue-specific adapter protein that regulates SRB1 protein levels at a post-transcriptional manner. And PDZK1 influence on lipoprotein metabolism is through its effect on SRB1. So now we were wondering, well, why do we have so many PDZ domains in PDZK1? What are all these domains doing? Are they all necessary, or how do they function? We knew from previous publications that the SRB1 binding site was likely to be the first PDZ domain, but we didn't know what these other domains were doing. So we made a number of transgene, one just with one domain that was not functional. We made another transgene expressed in the liver with 2 domains, non-functional, 3 PDZ domains, non-functional, and finally 4 PDZ domains. And this one was functional with recovery of normal cholesterol levels. We also found through a number of other studies that in addition to being able to bind to PDZ1, SRB1 was also able to bind to PDZ3, but with a lower affinity. And we found out that the role of PDZ4, which was essential, was not to bind to a cell surface receptor or to SRB1 or to any other protein, but it was necessary because it was binding directly to the membrane, to lipids in the membrane. So the PDZ domain had 2 roles. One, its association with SRB1 for 1 and 3, and its direct anchoring of the protein into the cell membrane. So then we wanted to see understand how SRB1 binds to the PDZ domain. So we did a crystal structure of PDZ1 and PDZ3 with the SRB1 carboxy terminal tail. And the way we did it was by creating a hybrid molecule like that. So what happens in the crystal structure, you have the SRB1 peptide here, 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 and here. So we get head-to-tail organization of these molecules with the SRB1 peptide interacting with the PDZ domain here. This is an artificial model, but this is how a lot of people who have crystallized PDZ domain were able to understand how the receptors is interacting with the PDZ domain. So we found out, so the PDZ domain in green here, for PDZ1, is kind of a globular structure that contains 2 alpha helices and 6 beta strands. It has also that carboxylate binding loop, remember, which binds to the carboxy terminal tail of the protein. And here we have our SRB1 peptide interacting between alpha 2 and beta 2 interacting with the carboxylate binding loop. This is a higher magnification of that, where you see the different hydrogen bonds and water molecule. And this is the last amino acid of SRB1, the leucine, which interacts with that YGF that I mentioned before. And we see that the interaction of the leucine here, very important with the hydroxyl group of the tyrosine through a water hydrogen bond network. If we remove that hydroxyl group from the amino acid, we drastically decrease the affinity of the receptor to interact with the PDZ domain. So I mentioned SRB1 can interact with the PDZ1 and PDZ3 of PDZK1, but that the affinity is much higher for PDZ1 with SRB1 here than it is here. And the reason here is that the sequence of the PDZ3 domain provides the formation of a much larger groove for the interaction with the SRB1 peptide than the PDZ1, which is a very tight groove. So is PDC1 heteroprotective? You know probably from the literature that if you make an SRB1 knockout mouse, these mice, when they are bred together with ApoE, die of myocardial infarction because of advanced atherosclerosis. So what we did was to breed the PDCK1 and the ApoE knockout. And as you can see, this is ApoE single knockout. When you add PDCK1, you get vascular obstruction and you get myocardial infarction. So indeed, PDCK1 is heteroprotective. The next model we were interested in was to understand, there were two things we wanted to understand. How is the carboxy terminus of the HL receptor necessary in steroidogenic organs, like adrenal? You remember that PDCK1 is not necessary for the normal expression of SRB1 in steroidogenic organ. So we made a knock-in mouse in which we removed, this is exon 10, 11, and 12 of SRB1. The carboxy terminus of SRB1 is at the end of exon 12. We removed 3 amino acids that are necessary for PDZ domain interaction. The result of that, when we use an antibody that recognizes the C-terminus of SRB1, is that the protein has completely disappeared in this delta CT, in that knock-in mouse that's missing these 3 amino acids. If we use an antibody that can recognize the extracellular loop of SRB1 and SRB2, which is a minor form, you can see that there is still a little bit. When you look at the liver, SRB1 is in normal condition is expressed in the sinusoid membrane of the hepatocytes, and it's almost completely disappeared in the SRB1, missing these 3 amino acids. Paradoxically, the minor isoform SRB2, which has a different carboxy terminus, was increased in these mice, and we still have to understand why this happened. But what we also learned from these mice is that in adrenal tissue, looking here, for example, with an antibody which recognizes all forms of SRB1 and SRB2, there is still a decrease in expression of SRB1, SRB2, as there is in the ovarian tissue. So one of our conclusion here is that carboxy terminus is still necessary for SRB1 to be expressed in normal amount in steroidogenic tissue. And probably in these tissues, SRB1 is interacting with a protein other than PDCK1, perhaps another PDZ protein. You can see using immunoperoxidase that in the adrenal, this is a normal expression of SRB1 in adrenal associated with cell membrane. There is a marked decrease in expression of the protein here, as there is in the ovary, and as there is also in the Leydig cells of the testes. These mice are characterized by an increased amount of cholesterol. These are male-female, delta CT mice, markedly increased, with a distribution of lipoprotein very similar to the PDCK1 and SRB1 knockout. So what we did also, we wanted to see if we could create another model of atherosclerosis. One of the problems with Monte Krieger's model of SRB1 ApoE double knockout is that the SRB1 knockout is sterile. The female is sterile. So it's difficult to produce these mice in a very high numbers. These SRB1 delta CT are fertile, so that's important in the model to make it easier. So we produce these SRB1 delta CT ApoE double knockout, knock-in, knockout, and we compare them to ApoE knockout. You can see that in the distribution of the lipoprotein, to add the knockout of ApoE shifts completely the profile of the lipoprotein towards VLDL size particles, abnormal particles. This is the ApoE, and this is the double here. And what happened, and that was pretty impressive, is that on chow diet, on regular lab diet, these mice, these double knock-in, knock-out mice, start dying at about 3 weeks and are all dead at between 70 and 80 days, so 10 to 11 weeks, okay? When you measure the cardiac function of these mice, all these mice, these double knock-in, knock-out mice, are in cardiac failure. And with these measurements around 7 or 8 weeks, okay? But what you see also in the aortic root of these double knock-in, knock-out mice, you see a large amount of atherosclerosis, you see vascular occlusion, and you see the development of myocardial infarction. And here, vascular occlusion using trichrome stains. So this is a new model on chow diets. We don't even need a high-fat diet, Western or pagan diet. On chow diet, these mice, because of a deletion of 3 amino acids at the end of SRB1, all these mice are dead compared to ApoE knockout, which are all alive in the same time frame. What is also a characteristic of these mice is that they develop anemia, as you can see here on the blood smear. They develop also thrombocytopenia, and they have very, very large spleen. Okay, that's the quantification of the size of the spleen compared to the 3 other groups: ApoE knockout, SRB1 knock-in, and wild-type mice. This is a double. And when you look at tissues from liver and spleen, you see that there is extramedullary hematopoiesis. So very striking characteristic of these mice, which all die by age 10 week of myocardial infarction, but have also a number of hematologic abnormalities. Well, that's the result of transferring to MAC. Conclusion: PDCK1 plays an essential and dominant role in controlling the steady state level of SRB1 protein in hepatocytes and optimizing reverse cholesterol transport. So therefore, it's a very important molecule if we all want to survive a number of years to provide adequate reverse cholesterol transport and basically eliminating cholesterol molecules from atherosclerotic plaques through the reverse cholesterol transport process. As a result, PDCK1 is heteroprotective. SRB1 interacts with the first and third PDZ domain of PDCK1. So we have really dissected the role of each of these PDZ domain. And there are several proteins, PDZ domain containing protein, which contain up to 12 PDZ domains. So you can understand how complicated it can be to do that. But there are different roles for these PDZ domain, interacting with cell surface or ion channels, but also anchoring the protein directly in the membrane, which can be very helpful. Yeah, so the PDZ4 domain is used to anchor PDCK1 in the cytoplasmic membrane. And then the characterization of that SRB1 delta CT missing 3 amino acids at the end of SRB1 mouse containing a deletion of that carboxy terminus suggests that there is a PDCK1 analog in steroidogenic tissues controlling the expression of SRB1. And we're still trying to identify it. And then the SRB1 delta CT ApoE knockout mouse could provide a valuable model for the development of therapies in atherosclerosis. And these are the people who have participated in the work. It has been a very extensive collaboration with Monty Krieger at MIT. We discovered originally SRB1, and that's how we got together doing research, and really has been a very nice experience. Other people have participated. These people have done deuterium exchange to determine if the structure of the PDZ domain mutated or non-mutated at different rates of deuterium exchange. And these people have helped with the identification of PDZ4 as a direct interactor with the cytoplasmic membrane. So again, I'm delighted to be here, and brings back a lot of good memories. And thanks a lot for your attention.
Based on your data, you suggest the other organs, rather than liver, is more important for the HDL transport?
Well, so the liver is not the organ that has the highest level of expression of SRB1, okay? But by its volume, it supersedes all the effects that you could get through disruption of SRB1 expression in other cells. So for example, the adrenal or the ovaries and things like that. So clearly for cholesterol control, the liver, just because of its volume, is probably the most important. Yeah. Mm-hmm. Yeah?
What do you make of the hematopoietic phenotype?
Well, I think the cholesterol content in the membranes of these red blood cells is clearly modified by the hypercholesterolemia and makes probably the membrane very fragile. Now, we have not done half-life, not measured the half-life of red blood cells in these mice, but I'm sure the half-life of red blood cells is markedly decreased. Yeah, thrombocytopenia. So that's more difficult to look at, but yeah, there is thrombocytopenia.
I don't know what happened.
I don't know about that. Yeah, I don't know. It's very possible.
You do need it? We do need it?
Yeah,
we need it.
What's the biological relevance of the binding to the two PDZ domains by the receptor?
Yeah. But don't put either of them in. Put those two together. And
so we have looked. We have. At first we were thinking, well, it's like, I mean, SRB1 oligomerizes clearly in the membrane. Okay. Yeah. Yeah, it may be helping to do that. The reason we found out that PDZ3 was also binding to SRB1 is because we made a mouse in which we mutated PDZ1, killed the interaction, and still the cholesterol was slightly elevated, but not elevated to the levels of a PDZK1 knockout. So we said, well, there must be another binding site. And then we did the crystal structures. We did a lot of isothermal titration calorimetry. I don't know if you know what, where we measured the interaction of peptide with the different domains, and we found that domain 1 and 3 are interacting with the SRB1 tail.
He has it on right now, so once he's through.
Well, it stabilizes, so it stabilizes SRB1 in the membrane.
There's your laser.
I think that's, I'm not sure, but I think it's probably independent. Because the cholesterol transport really has to do with the structure of the SRB1.
I can change it. We have time. I can change it.
Where does the
I'll change it now. Let's do this.
scavenger receptor end up in the cell? You keep calling it expression. Is it really expression, or it's degraded, or is it mislocalized within the cell?
So it's not mislocalized because the total amount really decreases. So, but I think the turnover of the receptor is increased. Yeah, that's right. Yeah.
But it's degraded.
Yes, it's degraded. Yeah.
And I'm surprised. Most scaffolding proteins are fairly promiscuous. They hold a lot of different things together.
Yeah.
And the only phenotype you're observing is this basically cholesterol
Well,
phenotype.
at first we didn't have a phenotype before we measured cholesterol. We just didn't have a phenotype. So so PDZK1 is also interacting with the cystic fibrosis chloride channel. Okay.
So it's an ABC transport interaction.
That's right. Yeah. Yeah. This one, it's interacting with an ABC transporter, which plays a role in multi-drug resistance. So it interacts with a lot of proteins. But what is interesting is that slight modification of the protein sequence of the PDZ domain is in fact changing the interaction, its capacity of interacting with a given protein. So it's pretty specific. It's still pretty specific.
Other questions? We're running a little ahead. This is good. Very good.
And Dr. Bissell earned her bachelor's degree at Radcliffe, Harvard, went to Harvard Medical School where she got her PhD, and followed on with an American Cancer Society postdoctoral fellowship there. She was the founding director of the Cell and Molecular Biology Division, and later the associate laboratory director at that Laboratory of Life Sciences in Lawrence, Berkeley. She now holds the rank as Distinguished Scientist there, which is the highest rank they have, and she also participates as a graduate faculty member at Berkeley in 4 of their graduate programs. She has been incredibly productive in her career with over 400 peer-reviewed publications. She's one of the nation's more sought-after speakers. The list of awards that she's received for this work is, I think some are listed in your program, but it's quite a lengthy list. She's a member of the National Academy of Sciences, has received the Wilson Award, and many others. Her area of expertise, I think, has brought a very unique and unusual focus to our understanding of breast cancer, and certainly was one of the pioneers in bringing forward the idea and our understandings of the incredible role that the microenvironment around the tumor plays, and this has been particularly active in the realm of breast cancer and our breast understanding of that. While she's never been a collaborator, Joe, she's worked in or at least I don't think she's ever collaborated with Joe, but I share certainly in their interest of the matrix and the niche around tumors and cells. Shares significant overlap, so she thought we would be an outstanding speaker as the keynote for Joe's symposium. So I won't say any more, Mina, and you get the whole hour, so you don't have to get off in 20 minutes. It's a pleasure to have you, and thank you for joining us.
Thank you. It's truly an honor, really. Thank you, John, for inviting me. I don't know if you did it or Joe did it, but I thank both of you. I would have come no matter what. So I wish I was a postdoc in Joe's lab or a collaborator with Joe. I always admired him. But the problem is that I didn't know any better because, as you heard, I was a chemistry major and then a bacteriogeneticist. What did I know? Nothing. So I come to do my postdoc at Lawrence Berkeley Lab, at the University of California, Berkeley in the virus lab, and everybody was working with RAS sarcoma virus. And it was such excitement, as you can imagine. I mean, in the early 70s, all of a sudden, the first oncogenic virus that was discovered by Rouse in 2011 started exciting everybody, the repressors, the whatever. And I honestly was completely ignorant, and I still am. I always liked talking to pathologists because in the days where the molecular biologists were saying, we no longer need pathology, all we have to do is to make a transgenic mouse and we'll know absolutely everything. I was saying to them, are you out of your bloody mind? Do you even understand what you're saying? But this thing is a section of the human breast made by this guy, Kurt Heinz. And those of you who know the pathology or the anatomy of the human breast know that we usually think of breast of making of 2 epithelial cells, luminal and myothelial, and then stroma, which is fibroblast and fat. Well, we find 12 different cell types in the breast. We haven't published this yet. I don't know what to do because now he's an assistant professor. He's no longer listening to me. But we have spent 8 years doing it. And other people are imitating, and I keep saying, Kurt, you're going to get scooped. Doesn't go anywhere. Okay, so I come to virus lab, and you can imagine these 12 different cell lines have to know what to do in that structure. And what do we know about that structure? It's really not that, well, now maybe we know some, but there's still, as you will see, because they ask me to come and give keynotes usually, because, first of all, it's a lifetime work. Second, I speak loudly. Third, just like Joe, I am like Italians, but he is Italian. He's like original. Maybe that's why you and I have always liked each other. If I don't use my hand, I can't talk. And if I don't walk, I can't talk. So anyway, I came to Virus Lab, and what they had was chicken real fibroblasts in a plastic looking like this. This was our normal, and then we dump in some Ras sarcoma virus, and this was our malignant. Now, honestly, that didn't make sense to me, because I kept thinking, how could you just add one virus and get it? So when we were in my own lab, first of all, I noticed that none of these molecular biologists had ever looked at the tumor. All they were doing, even the MD ones, had never looked at the Ras sarcoma virus tumor, but that's how it looks. Ras discovered it in 1911, and at 1911, people really didn't know very much, and it's amazing because he took this tumor, dissociated it, put it in a dish, and then injected the filtrate back into the chicken and got another tumor. So he proved the Koch's postulate. Now, before I go much further, how many of you haven't heard me? Put your hand up, please. Don't. Well, you see, there are only 4 or 5 of you who haven't heard me. You haven't heard me either.
No, I heard you. Your microphone is off.
Oh, my microphone is off. I know. You see, I know such a I'm doing this. I have such a loud voice that I didn't need it. I turned it off when he was talking because I was making bad stuff behind. Okay, he needs it, but you guys were hearing me anyway. I'm not going to repeat myself. Okay, so I noticed that nobody was doing this, and we began to read the literature, and we found some crazy stuff. And a postdoc at that time, and I, David Dahlberg, we started injecting the virus into the chick embryo on a stage 24. Don't have time to explain. I have to talk to you about 40 years of work. And I tell a story. I tell the beginning, the middle, and the end. And please forgive me when I go fast, because I really like to get to the end of my talk, because I'm getting to be so old that I don't know who else will talk about this. And most of the stuff I'm telling you is not in the textbooks. Even though we invented the field of microenvironment, we invented three-dimensional structure, we showed a whole lot of things, but if you had the former head of the NCI here, he would walk out, because he still believes that a single oncogene is enough. And in fact, he is so adamant that he took my merit away. I don't know how he could do that, but he did. No, you had it in '99. I had it after when he took it away. I mean, I can't believe this. But anyway, there are a few young people in the audience. I usually just talk to them. So don't let people stop you, okay? So we injected the virus in the chicken embryo, and we showed that it had the activity of the pp60 Sarc, which is the product of the Sarc gene. It was expressing everything else all over the embryo, and the embryo was growing and growing and growing and growing, and we published this in Nature. In those days, it was easier to publish in Nature. So in 1984, they published it. So nobody took attention at all, and I don't blame them, really. It was so exciting to think about oncogenes and suppressor genes and have one single gene that you could, hang your hat on. Who wanted this mess that in the embryo it doesn't do it? Who cares? So we had to do more experiments, and we eventually took LAC-Z, attached it to pp60 Sarc, and as you see that gorgeous feather, every single one of those blue cells could be a tumor, and they're not. Now, if we take that wing, dissociate it, put it in a dish, overnight, it would pile up and make a transformed monolayer on top of each other. So think about this. We had the virus, we had injection in the chicken, you get a big tumor. We put it in the embryo, it doesn't. We dissociate the embryo and put it in a dish, it does it again. What is going on, and what did this tell you or told me is the following. That context, i.e. the microenvironment, determines what even a potent oncogene can do. But what do we mean by context, and how do we study it? Now, here are the things that amazed me again about why I can't find answers to them. One of them is this good question of why the chicken does it, why embryo doesn't. We have a very nice paper, a couple of papers. I love to tell you about this, but if there is time, because I have a lot to tell you. So ask if you are curious. The other thing is, I don't even know if pathologists know this, that we have somewhere between 30 trillion to 70 trillion cells in our body. Think about it. It's more than the national debt of US and Europe and China, everything put together. 70 trillion cells, and what? They all have the same genetic information. All have the same genetic information. How the heck do they know to do all these things? I mean, look at me. This, that, this, all have the same genetic information. How do these cells know? So I began to wonder about it, and I gave a TED talk, and I had 600 people who were all, none of them were scientists, and I had to make acrobatic to make them know. Did you see it as they went across? Or did I? Okay, so 0, 0, 0, 0, 0. Okay, so how do these cells do it? But most importantly, how do the cells remember to be a nose and not turn into your elbow, right? They could, and you know why? You remember Dolly? Dolly came from a frozen piece of a sheep mammary gland. Somebody in Scotland took a cell from a frozen mammary gland, and what did he make? A whole dolly. Now, I rest my case for those people who always say terminal differentiation. Terminal differentiation is a figment of 30 years ago or 40 years ago. It simply doesn't exist. These two experiment very simply. The dolly and what I just showed you should tell you that the differentiated state is unstable, right? So I began to think about BRCA1 or APC. You have cancer is an organ-specific disease. Again, the pathologists know this, but molecular biologists have no idea. They still think they can cure cancer with one single bullet, and that's why we are not succeeding. If it's not this bullet, it's that bullet. If it's not that bullet, it's this bullet. Well, cancer and aging have so much in common that is not even funny, and until such time that we cure aging, we can't eliminate cancer. We could cure cancer, we could do all sorts of other wonderful things, but we can't eliminate it. So that's another figment of people's imagination. So, I spend my life answering this question. How is tissue specificity, noseness, elbowness, prostateness, so the gentleman would listen, is remembered? How does one study this program in mammals? I wish Drosophila had mammary gland, it does. How is the program lost in cancer and aging? And as I said, when you age, after 50, cancer goes up logarithmically like this. And why is that? And I haven't proven it, but I have a very good hypothesis. And how can one use this information for therapy? Well, that's a lot of stuff to tell you in the next 50 minutes, but I will try. So I thought I'd give you the conclusion first, okay? Here are the conclusions. The differentiated state is unstable, and the environment regulates gene expression, and its gene expression is regulated at the level of the tissue architecture. It is the architecture that actually determines organ specificity, okay? Tissue architecture is dependent how the ECM, microenvironment, signals to the nucleus and to chromatin. I said that in 1982. I can't tell you how much ridicule I received, including people who told me I was like a, never mind, never mind. Okay, if I start telling you those anecdotes, I'll never finish. Okay, so it is due to ECM, and I postulated because I had read the literature. I don't know why I don't have my 1981 review, but I had read the literature and I had shown that the minute you take a cell out of the body and you put it in a dish, it completely forgets where it comes from. Okay? So I said, what is this stuff with constitutive gene expression, inducible gene expression, whatever. There are no genes in your body that are constitutive. Nothing. They change either qualitatively or quantitatively, and at times quantity, as in collagen and tendon, becomes quality. Okay? So tissue architecture is dependent on that. I suggested that the ECM actually signals. This is just, I had written it before integrates. And I said that it needed to have a receptor. The receptor needed to talk to the cytoskeleton. Cytoskeleton had to talk to chromatin in a way that when you add the ECM, it reorganizes and does something else. Now, this was the thing. I think you must have been in one of the meetings when the speaker and I had a very interesting discussion. I will remind you of this. But anyway, we can phenotypically revert the malignant phenotype in the 3D assay, not in 2D, but in 3D, despite genomic instability and many mutations. You read these old papers, and I have even one before that, but this is the best. And vice versa, we can take a perfectly normal mouse, put MMPs, which destroy the ECM, in the middle of pregnancy. I did these experiments with Zina, because she was an MMP person, and I was a mammary gland person, so we sort of got together, and it actually was made in my lab. We attached it to a promoter of a milk protein gene called WAP, or whey acidic protein. It comes up right in the middle of pregnancy. We made a mouse. It destroyed the structure in the middle of pregnancy, and these crazy mice thought they were involuted. They started popping all over. They started branching all over again, and as time went on, they got cancer. Never introduction an oncogene, never taking away the suppressor gene. They all made tumors, and they died of it. Okay? So that was in 1994, 95, 96, 97. I don't have time to tell you how many of these we did. But that's the other side of the coin. So I also made this hypothesis that if I'm right, an architecture is in fact the determinant of tissue specificity, then what should happen? That we should be able to change the architecture of a tumor cell and make it think it's normal. And we have done both of these things. I don't have time for the mouse stuff, but if those of you are interested, we show in a paper in Nature in 2005, and by Derek Radisky, who is now a professor at Mayo, that if we add MMP3 from outside, we get genomic instability. In no time at all, in 2 weeks, we get increase in amplification and all sorts of things. So much for that.
The microphone fell.
Microphone again?
Fell off.
Oh, fell off. You poor thing.
Can we put it?
Yeah, you can put it there. I don't put it there because I get hot in the middle of my talk, and I have to do a little striptease once in a while. So I want to try to keep it on here. All right. So anyway, you can see that if we also change the structure of a perfectly normal cells in 3 dimensions in culture, it starts completely thinking it's malignant and does all the things that malignant cells do. Okay, so that's what we did. And the new conclusion that I can tell you, and some of them are not published, is that growth and homeostasis are dependent on the nature of the ECM signaling and laminin to nuclear actin in breast cells, okay? The problem in cancer is not growth. The problem in cancer are the changes that occur in architecture. As you move through aging, and as the ECM gets corrupted. When the ECM is healthy, you are looking gorgeous. But these things are not good for you, okay? And as you age, it becomes dissociated, split up, upregulates other thing in the stroma, does the whole thing, so you get mutation, 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 until you're blue in the face. You will not get cancer unless the architecture is compromised. That's why cancer takes 20 years. Childhood cancer is something else, which is a different beast altogether, and we can talk about that if you like. But for all the aging population, although I must say, guys as early as 16 have a precancerous lesion in their prostate. When these kids die of a motorcycle or something, it's just, and if they took my breast and the prostate of Joe, since he's more or less my age, except I think he's younger, if we will have carcinoma in situ, we would have all these things that cells do, precancerous region. We'll have all sorts of things, okay? But we don't yet cancer. We don't yet get cancer, which is the title of my talk. Okay, so we said all these things, and I propose that these findings have profound implication for dormancy, for diagnosis, and for therapy. Okay, so I was doing chick embryos, and I was doing what? Glucose metabolism, because I thought this oncogene stuff is so competitive. People were killing each other to get the Nobel Prize, and the wrong ones got it anyway. So it was just really a mess. And I thought, I'm not going to enter this. So I said, what's interesting? And I said, Warburg. Why is everybody has forgotten about Warburg, or they are saying he was dumb, he didn't know, and here he won the Nobel Prize. So I started doing glucose metabolism. I swear, I would get up there with all the energy I had as a young woman, and all the passion and whatever else, and my audience would glaze. Metabolism? Chicken? So we did this. We said, this at least is more interesting to them. And besides, we can hang it on something that I care about, my daughter would care about, and other people would care about, and that was breast cancer. So we chose mammary gland as an experimental model because it changes. It goes from virgin, pregnancy, lactation, involution, changes all the time. When you take the babies away, it comes around, gets reorganized. We don't know how, although I think I have a clue. And then it is ready to get pregnant again. How does it do it, right? Okay, so here is a picture of a mammary gland of human. We have about 5 or 6 of these. It looks like a gorgeous tree. And we said, okay, the good thing about mammary gland, up to that point, everybody was studying growth. And you know why? Because they couldn't get any cell in culture do anything that was tissue specific. So they all studied growth. And I said, well, mammary gland is good because it makes milk. And it changes so much during different times, so I want to find out how it does it. So we looked at this and we said, even that is too complicated, so let's just take one portion of this, and that was the formation of an acinos, and it's one layer of luminal epithelial cells, beautifully polar myoepithelial cells that squeeze it, and this thing around about which I knew nothing, and this lumen where baby sucks. Oh, by the way, I tell you, this lovely woman who gave the first talk, where is she? She gone? I want you to examine me because I fell on my head when I was 8. I fell on my head when I was 8. I cracked my skull. I went like this. I was a tomboy. I was jumping over a rope with a 15-year-old boy. And I cracked my skull. And I'm totally deaf in my left ear. And when pathologists look, or whoever looks at, not yet pathologists, but the other people, when they look at my brain, they all said, you're about to have a stroke. Because this side is completely gone. I don't have any hearing, and I can't remember any name worth a damn except Joe Madri today. It's really awful. I don't forget a thing about science, but anyway. So we have this gorgeous structure, and the babies suck, and somebody else talked about that. Every time I listen to these talks, I think, oh, this is so exciting. That's what I should be studying. But unfortunately, we only have one life. So this thing inside is milk, so we said, great. And then we took these cells, put them in culture, and in a day or 2 days, completely forgot they're supposed to make milk. They changed shape, they changed polarity, nucleus changed. Here they are. Here is very old micrograph taken by my postdoc, Joanne Emmerman, even before she came to my lab. Beautifully polar, or very lovely organized nucleus, fat droplets, secretory activity, Golgi, etc. Here is the same thing in the same magnification. Look at this nucleus and look at that nucleus. Now, I want you to pay attention to something. This thing. It's going to be the last part of my talk. It's the most exciting finding we have had. So take a look at this. I never paid attention until 40 years later. Okay, so we do the section of the mouse. Here it is, an acinus, fat droplet, and this thing around them is laminin. And then my postdoc said, laminin is part of a basement membrane and whatever, and I learned from them. Somebody else taught me about collagen. I tell you, I owe these kids so much. So we said we want to do this. And 10 years passed before we succeeded. We used to make this tumor in my lab, and I'm sure Joe used to do it too. I remember Joe Helms took some of that to my husband's lab. People from NIH looked at it and said, oh, it looks like a basement membrane, this tumor secretion. And I made this assay, and Lawrence Berkeley lab would not patent it. And if they had done, I would have been so rich, like you. I wouldn't have to write these grants that people have either didn't give it to me or took it away. Okay, so here are the cells sitting here. Then you put this thing around them in no time at all. In 4 or 5 days, you make this. Even the sizes are the same. And we said, are they looking good? I mean, milk is here, and basement membrane is here. They are polar. The most important thing in your body is polarity. So we said, does it make milk? Yes. They look gorgeous. They make milk. The red is milk, is beta-casein. We got the antibody from a person called Charlotte Quetzal, and she was kind enough to give us the cells. And these are nuclei, and there are 2 of these things coming together. And of course, I am getting older and older and older, and the kids did that. Okay. So, are these concepts applicable also to human breast? Because after all, that's what we wanted to do. After all, we wanted to answer something about cancer. So I did a big thing with my colleague, Ole Peterson. He came to me, was a young assistant professor in Denmark. He was an MD PhD, and by the way, I'm the only single PhD in your program. Everybody is MD. So, you know, I am ignorant and say things that MDs wouldn't say, but I think we have shown them enough that I think it may be helpful in your practice too. So here is the reduction mammoplasty, and the great thing about that is we don't do it to women, they do it to themselves. And so they goes into garbage, and we took it out, and we dissociate, it looks like that, but this doesn't look like that. We put it in 3D, look at it. Even the sizes are the same. So they make terminal ductal lobule unit, very exciting. And we said, okay, if the normal cells put in 3D know they're supposed to be normal, can we take malignant cells from a tumor or a primary malignant or a secondary malignant cell or even a cell line and put it in 3D, and would they remember they are malignant? And if they do, we have an assay for any kind of normal and malignant human epithelial cells, that they are now behaving like human in vivo because the normal here was behaving like normal, so the tumors would behave like tumor, and sure enough, here a single normal cell, it grows, it stops growth in this laminin-rich gel. These are not single cells, those are like that, propidium iodide and whatever. And when we put malignant cells, look at them. Every one of them does it. is like having thousands and thousands and thousands of human normal acinas and malignant, and these are clonal. You can take them out, you can put HSRNA, you can knock out something, you can do, and we have done a lot of those things. Every one of them do it.
Why is
So,
the size bigger?
I'm sorry?
Why is the difference in size of the acid
Well, we
reflection?
blew it here. What do you mean? There's
The-
difference in size?
Your micrographs there, the pictures.
Well,
Are they
because-
different mags?
No, they are not. Oh, you mean this as opposed to
No,
that?
no, this as opposed to that.
Well, this is malignant. It keeps growing, right? A tumor keeps growing in you after it loses polarity and after it has about hundreds of mutations.
Those aren't polar then? And if they're in a laminin gel, they wouldn't be polar?
Yeah, if you don't, well, I don't know in what gel you could put them that they would exactly do this, but if you put it in a laminin-rich gel, where the normal cells are doing the right thing, the tumor cells don't. They act like a tumor. If you put them in collagen, these are inside out. And that has to do with something that I don't think I put in my talk, and that is, where does the laminin come from in vivo? And it comes from myoepithelial cells. And I didn't know that, and it is so exciting. So myoepithelial cells do the same thing as EHS tumor or matrigel. That's why this thing works, okay? So you see how gorgeous they look? Now, here. So we have a paper with Johnson and Ole. It was done in his lab, but it was in my grant that I wrote about what is it in vivo that does this. So in vivo, they're surrounded by fat and myoepithelial cells. We isolated luminal and myoepithelial cells. We put them in gel of EHS, of course. They look gorgeous. Here are the nuclei. Here is basement membrane. Here is epithelial-specific antigen. Here is whatever. And we put the same cells, luminal cells, in collagen. Look at them. They're completely inside out. So ECM is not ECM, is not ECM. Each ECM does different things, okay? So here there are no basement membrane, but they are making gobs of basement membrane proteins. We have a paper in Journal of Cell Biology, 1990. We show that these cells are making 100 times, 200 times more than these cells of ECM molecules. But they can't organize it because the polarity is backwards, okay? So here is the ECM inside and a specific antigen outside. Now we come in and add myoepithelial cells, and voila. We made the same, the typical tube of the mammary gland. Not everyone does it because myoepithelial cells go to themselves, luminal, but once in a while when they meet each other, they make that. Gorgeous. And we showed that this is because only myoepithelial cells make the A chain of lamina, okay? And that's why when the myoepithelial cells get lost as you get tumor, here are normal, you see how gorgeous they are? Here are the tumors, 5 different ones, now we have hundreds. Laminin is basically gone because myoepithelial cells are gone. Or if we do have myoepithelial cells, they don't do that function of reversal because they don't make laminin. Are you with me? Okay, I have to go fast. Okay. Then I wanted to do a comparison about why normal know and why malignant doesn't know. And we made a model with Ole where they had spent 12 years taking cells from a real woman who came with reduction mammoplasty. They put her cells in a culture. I mean, if they had done it 20 years ago, now they would get sued like that other book that really upsets me about HeLa. You know, people are making such a fuss, and it just doesn't make any sense to me. But anyway, so we took the cells. They had put it in a dish. No serum, no hormone, nothing, except a little EGF. And they grew, and somewhere in the middle they came and took the EGF away, and I arrived around that time, kept injecting it into the mouse, it wouldn't get tumor, and eventually a tumor got formed. And when we looked at those different cells, pre-malignant, malignant, whatever, we had the first model of human cancer, breast, from beginning to the end, and we have all of the passages. It took 20 years, and we did so many things. And we sent this to Cell, and it took them a year, and then after a year, the reviewer said, oh, but you only have one model. And I said, good, you have another 20 years, you do it. So we divided it and sent it to Cancer Research. And again, this is for the young people. Publish your data. If it's a good paper, people read it. These different papers get a lot of citations, okay? So we put them into the normal and malignant didn't look different. I put them in 3D and look at them. Passage 60, P53 is gone. There is amplification, deletion. I did this with Joe Gray. The paper came out of Cancer Research in 2008. MIG gets amplified. A whole lot of other things go. Now we are in passage 500. They still think they're normal. Now you remember that chicken with RSV, right? Okay, pre-malignant cells, when we took the EGF away and waited for about a year before they grew, etc., they have a lot of mutation, but the structure goes before malignancy sets in. The structure goes before malignancy sets in. Again, remember when I dissociate the feather of the embryo, they get transformed again. Okay, so I said, here is a good model. These two came from the same background, same genetic background. These are the non-malignant, these are the malignant. Look at that actin. It's growing the way I'm showing you, yeah? And what if we found a way when we put one cell of each, we add something that tells these cells to organize. And we used beta-1 integrin inhibitory antibody. Okay, and I don't have time to tell you why, but we had very good reason to do that. And we brought the level of beta-1 integrin, which was 5 times higher here than this. And they have EGFR 6 times higher. They have this, that, everything they had, but the balance was completely gone. So we said, okay, let's use it in such a way so that we bring the 5x or 6x to 1x. If we take it to 0, they all die, because ECM is completely responsible for the reason that your tissue cells don't pop up all over the place. You take it away, they all die, okay? We have a paper in Science in 1999. Anyway, 95 or 99. So when we did that, here is what we got. Is a very old stuff. Of course, it's not 100% normal, but look, we had beta-1 inhibitory antibody only in 3 dimensions, and that brings down the beta-1 to the level of 1x, and these silly cells think they are normal. They have stopped growing. They have all the other oncogenic pathway getting organized. It's really remarkable. It was in the cover in Journal of Cell Biology. I didn't send it to fancier journals because I thought they're going to kill us. But they killed us too, but at least they put it on the cover. So we said, does one do it or all of them do it? This is the reverse of what I have shown you. These are the malignant cells, and these are the reverted cells, okay? So why did they stop growing? So we started saying, and then people kept saying, oh, you selected. I said I selected 10 to the 6 cells in 3 days. That's ridiculous. So we did an experiment to show that reversion is reversible. Here are the malignant cells. Here are the non-malignant cells with the antibody, inhibitory antibody. We dissociate this. We put them in a dish. With these, without the antibody or like that, with antibody or like this, we can do it over and over and over and over again. If we take these cells as they are, inject them into mouse, 0 tumors. If we inject them, dissociate them, and inject them with beta-1 inhibitory antibody, which I'm hoping very soon would turn into a drug that we could use with chemotherapy, mouse remains completely normal, and the tumor dies, okay? So what does this say? It says that phenotype is dominant over genotype, even in tumor cells. Now that used to enrage some people. I know when I said it in Europe, they gave me a clap, right? But why are people so surprised? They didn't give me a clap. They clapped for me. You have to excuse my language still. I say. I heard somebody crack up, and I thought I'd better correct it.
What happens when you add beta 1 to the wild type cell?
That's exactly right. What happens? If they are a little bit going toward becoming malignant, because remember, Robert, they get corrected. If we add more, nothing. Absolutely.
Disrupt the balance in the wild type.
Well, you're adding beta 1 inhibitory antibody. It does nothing. The cells are.
The actual beta 1. You add beta 1 to the wild type cells. Does it change that?
Oh, to increase it, they become disorganized. Yes, yes. It's another oncogenic pathway. It's like having too much EGFR. Okay. So here is the big thing. It's every one of these are a paper. Beta 1 integrin signaling, you added at time 0 to single cells, remember? And they somehow get corrected, and I will tell you how in a minute. What's happening to my tongue? Okay. So we revert. Beta 1 integrin inhibitor, we said, why do they stop growing? We had EGFR inhibitor, they do that. MAP kinase, they do that. PI3 kinase, they do that. Any one of those talks to everyone else, integrates the signaling in 3D. There isn't a single thing in your body that is 2D, okay? So that's the source of integration of a given architecture in your tissues, all right?
I think the mechanism is of adding beta 1 integrin, because most of the time, integrins are, heterodimers, which have to be active as heterodimers. So what's your proposed mechanism?
What, this thing?
Yeah.
Okay, I will show you, okay? Because they all talk to each other, okay? You have to have the right balance in order to get the integration. But just wait a little bit until I show you more data.
Yeah, my question is, what is beta 1 chain doing? And how is it affecting the phenotype?
Because it turns on all these other different pathways.
How? I mean, does it
Oh, you mean at the level of the molecular thing at the surface?
of the
Ask
cell.
Martin Schwartz and yourself. I am trying to tell you something else. I know it, but I am trying, because there's so much on the integrins, okay, for crying out loud. They talk with their 3' end to the cytoskeleton, and I will show you what they do to, Okay, so form and function are related dynamically and reciprocally. Now, if I'm right and insisting, and I really want to take this jacket off, the rest of you who are falling asleep have my excuse. 4 o'clock in the afternoon, people should be having tea.
It's only lunchtime in California.
Exactly, I'm awake. I'm awake, I'm just hot. I was going to say I feel bad for the audience because they're not awake. And they have already, okay. So form and function are related dynamically and reciprocally. And then it occurred to me that if I'm saying this, there are all these things that were not in these pathways, like glucose metabolism, right? So I said, what about this? What if, do they change? If everything has to be organ and tissue specific, do they change? Now, in my youth, I did this crazy thing. When I went and had my own lab, I was amazed at the way we do cell biology. We open the incubator door, pH changes, temperature changes, this happens, that happens. So I joined Lawrence Berkeley Lab after my postdoc, and they had a lot of engineers, and together with one of the professors there, Al Bassam, we devised what we call a steady state machine. It had 2 septum, and we were using a lot of radioactivity those days, okay? So we could put the cells, it had 30 things, and we could put the cells, come in and inject radioactivity, and then in 30 seconds, we could bring it around on the other septum, this one, and then remove the cell without changing pH or temperature. So we could do kinetics, okay? I'm not showing you the data, but when we did that, we showed that Warburg was right, that no matter how much you tried, the glycolysis, aerobic glycolysis always went up. But let me see what I have here. No, I didn't put it in. But then we said, okay, that's great, because most people were measuring lactic acid production without taking in glucose intake. It's just like having a patient in the hospital giving orange juice and then measure, not showing how many orange juice they drank, but measuring the urine or vice versa. Doesn't work, so you have to do ratios. When you do the ratios of what's output, what will work? So they were always higher. So we said, okay, is it because of what Warburg said, which is that the hydrogen transfer pathways are messed up? Well, they weren't. I have his first author paper in Science in 1976, so you can see how old I am. It's older than your mom, right? So, so we showed using 11 curie of tritium. I had people surrounding me when I was doing that. And my chemistry I was still remembering, but we showed that the hydrogen transfer pathways are not touched. They're the same. And yet the aerobic glycolysis was up. So we said, what is it? Is it the shape? We measured the shape. Is it, you look at my papers actually this picture now is in Journal of Cell Science, January issue, and I quoted my old papers on glucose. So for 30 years I tried to get somebody in my lab to look at this in mammary gland. Nobody would touch it. Then glucose metabolism got so famous again. It's a big deal now. All these people, like, you know who, they all have companies. They are all doing whatever, and as a result, it was very hard for us to publish. So when I added the radioactivity in this machine and then did a thing that Melvin Calvin had done, where we would take the glucose metabolites, run them in a paper chromatogram that was that big, and then we put it in a phenol tank and do this. It was the first system biology. We would get a pattern of glucose metabolites in different cells. That's liver, that's fibroblast, muscle looks different, breast looks different. So even glucose pattern is organ and cell specific, okay? Now, this guy came to my lab. I don't know how the Japanese do this, bless his heart. So this is normal, this is malignant, and these four are the reverted things, and actually we had more. We did arrays, old-fashioned arrays. It nearly killed me because we were so bad at it, but we did it. And he took the arrays of the normal and took 30 different metabolites and put them at one. And then he took the same 30 metabolites in these arrays and in malignant, and as you see, they're all over the place. Now we took the revert, and I'm not showing you the data, but I will show you the paper that came out. They collapse. In every case, these collapse close to the normal when we revert. So I said to him, take the glucose away. So here are the normal. Increasing glucose concentration is like adding the beta 1. If you don't enter it from outside, it doesn't do anything. They're okay, they're still normal, they're still young. Here are the malignant. You take the glucose away, look at it. And this is what I had shown in the 70s, that when I took the glucose away from the fibroblasts that were looking malignant, they look normal, like what I showed you in the beginning, very beginning. Now, if we took it if we add a lot, like 25 millimolar to normal, they began to mess up, and they began to become aerobically. So here was the case. Look at this. 0, 0.175 are perfectly good. 1.75, they already start growing. 5.5, a mess, 17.5. Folks, we grow our cultures at 17.5 millimolar glucose. And we give them a lot of serum. And we put them in a flat surface of plastic that makes them like a wound all the time, okay? So it's nothing like what happens in your body. Now, this next time you have your second cheesecake, remember, added sugar is very bad for you, okay? So my two big advice at my old age is that exercise, because it keeps your ECM healthy, okay? You can't go and do surgery because you cause wounding and a whole lot of other things. You may look good, and after a while you look horrible, but, but the point is That doesn't do it. But exercise does it, good diet does it, and take away the added sugar and your red meat, and you will be really safe. You can do it still the things I do in my old age. Okay. Here was a pattern when we revert, and you look at we had 400-fold GLUT3 in malignant cells. And when we try to revert them in one day, they become like that. And all of this, there's a lot of stuff in here. This came out in JCI just between 2013 and 2014. Okay. Here are the connection about why these things all talk to each other. I'm not wanting you to memorize this, but please just pay attention to this. Here is EGFR, here is beta-1 integrin, okay? Here is GLUT3, which is the receptor for glucose. When that goes up, those get activated. When those go up, this gets activated. And we discovered a new pathway that people even didn't know existed because it acts only in 3D. It does not work in 2D. They switch from completely the way they work, okay? So we put glucose removal up there, and we said, reversion is a dormant state, okay? How does a cell become dormant after metastases? So it took me many years until I had this brilliant, no, before I do that, I want you to go back and read this paper in Science in 2015, those of you who are skeptical. They were working with normal people, but then they began to sequence the normal skin as opposed to the tumor. Every oncogenic pathway was activated in almost everybody. I haven't put the data in, but you can look. You see that they're all active, but they didn't have tumors, okay? So it is completely something. Here is a normal tumor, normal tumor, normal tumor, normal tumor. Now we did this, the opposite of this 20 years ago, right? Here are the beautiful normal cells, very lovely polar. These are not as polar at the apical, but the basal is gorgeous and they stop growing. Okay, so this model that we have developed and took so long is an amazing model. It's like the eye of the embryo, of the Drosophila as a model. Because to go from normal to malignant, you have hundreds of pathways, things that mutate and go up and come down and do it. Going back in this model, from malignant to normal is one step. So that gave me the promise that we can then solve how this three-dimensional structure is made. How is it made? So I have to tell you that this molecule absolutely rocks. If you didn't have this, you wouldn't exist. And it is as important as P53, and I'm being polite. It could be even more important, as you will see in a moment. So let me just say a word about drug resistance, because I read that, I raised that. We have quite a few things on drug resistance. Michael Gottesman at NIH finally invited me 3 years in a row saying the only thing that makes sense now is this study. Because all those things they did wasn't working. It has all to do with polarity. We took 6 different apoptotic agents. They're used in clinic. They're used by whatever, and they all have different pathways. I'm not showing it to you. It was in Cell. It was 90% done by Valerie Weaver, who has her own lab. Very smart gal. She's at UCSF. It came out as Cell in 2002, and you should see all the things we had to do. But here is the conclusion, that the hemidesmosomes and alpha-6 beta-4 integrins and NF-kappa B are involved in polarity-induced apoptotic resistance. If NF-kappa B is way up, you're not polar. If alpha-6 beta-4 to the hemidesmosome is messed up, you're not polar. Both cells, normal and malignant cells, die. You put them in 3D, the normal gets organized, doesn't die, the tumor dies, and everybody said, oh, it's growth. Well, we put them in collagen, where they are upside down, they both die. It doesn't have anything to do with growth. Oh, it's the genome now. No, because when we revert the genome, it's perfectly resistant. So it is a model for dormancy. How is it that dormant cells get out, sit somewhere, and are resistant to the drug? And the patient, primary tumors, it's killed, few other tumors that are whatever killed, but the dormant cells are not. Okay. So when this guy came, he's now at the Hutchinson Cancer Center, bioengineer who knew everything about endothelial cells, everything about blood vessels, everything. I mean, I don't know how this kid does it. His mind is, you know, I used to have apparently photographic memory, and people used to always test me, and I was so mad all the time. And then when I fell on my head, I lost most of it, and I thought, good, now I am a semi-normal person. But this kid seems to remember everything he reads. So this paper was on the cover of July issue. It's very complex, but it's a gorgeous paper. It's the first paper having a model of dormancy with human breast cells. And this was what was on the cover. Just listen to me for a minute. What he did was that he injected first metastatic cells into the animal, MDA235. Then he took the primary tumor. Then he took the tissues of brain, bone, and liver, and lung, excuse me. And that's where the dormant cells were sitting, because he had labeled them and they had EGFR, fluorescent dye in it, and you could tell. Then he took a non-metastatic cells, which was invasive, like our cells, okay? And he went to David Leiden's lab, injected into the heart, did the same experiment, exactly the same thing happened. But he noticed that they all come out and they sit on the blood vessels. Nobody knew where dormant cells sit. They come out and they sit on the blood vessels within these tissues, just quietly. Then he made a model in culture of 3 different layers, imitating what is in vivo, because we wanted to find out a whole lot of things that we couldn't do in culture, and that's the result of that 3D. He has a layer of either blood precursor cells or lung fibroblasts. He puts on top of it endothelial cells that he has stabilized, primary human endothelial cells that he stabilized with a little virus so they could live for a little bit. They form this gorgeous structure. These are the dormant cells. But once in a while, we would see that they make a huge tumor, and because they were new adjuvant cells at the end of the dish that didn't have a place to go, so they would touch the thing and they start sprouting vessels. So he took those. He did enough with these. He did the whole protein assays and did everything. He could show that there are laminin, as I have shown you. Laminin is responsible for the cells to do all of those things, TSP1 rich, etc. And he did the stuff here. He did, and you can see it in the paper about all these things that actually wake that up. And look, they're even in the same dish. The difference in microenvironment boggles my mind. It's so local, like politics, right? It's amazing. From door to door, this neighbor says, this neighbor. Okay. So neovascular tips compose micrometastatic niches, and he has this whole thing with whatever. It doesn't matter. I don't have time to tell you, okay? You can read the paper. Okay. So what on earth was going on? Let me see why I don't have. Okay. When I was going to tell you about drug resistance, I also wanted to tell you about the fact that we asked a very interesting question. We said, you give lapatinib to patients who have a lot of high level of EGFR, right? Half of them don't respond. The other half relapse in 1 month. It costs billions of dollars to make that, right? And these poor patients pay God knows how much to have this. Why? And then I began to think maybe it's because a lot of these drugs are developed in 2-dimensional culture. And I said, let's take this data, these data. Here is EGFR inhibition. As you see, here is the tumor, here are the reverted with the inhibitor to EGFR, okay? I said, let's use this as a screen, and let's use the morphology as something that tells us that this particular cell is resistant. So what we did, we made a cDNA library of these, put it back in themselves to disrupt those things that were enabling the cells to revert, okay, to do that. And we began to find in the big culture like that, once in a while, these structures. So my poor graduate student, her name is Young, and she is a Korean gal, and she did a beautiful job because we weren't doing hardcore molecular biology. We were just using logic, saying this idea of using this knowledge for 3D therapy. So they had some like that, and it's a huge long paper. Again, this one was not in well, this one was in PNAS in 1978, but that paper is in JCI, again in 2012 or something like that. And if you look, and so we discovered 5 different molecules. One of them was called FAM83A. Somebody else discovered FAM83B. There are a whole new family of oncogene people didn't know exist, okay? When we put it, you can see that they, with high level of FAM83, they do this, that. Why? Because it's downstream of EGFR and PI3 kinase. It's one of the scaffolding proteins that actually regulates, okay? So when we put it in the animal, you see there is no difference in growth rate with and without. A low level of this added with antibody stops the tumor. But if you have high level, they do not respond to lapatinib. So we did another experiment. We did gavage, whatever that, some wonderful guy went ahead and did that with the animal. They had the tumor. We gave them lapatinib. What happens? FAM83A goes up in a completely different fashion. So here is one reason why the EGFR therapies, one of the reasons, and I'm sure there are many others. We have 4 others we have not identified because we didn't have any money. I lost a lot of funding from the budget thing and from NCI for the reason I told you. This came out in Clinical Investigation 2012. Please look at it. I think it's very important for people who do therapy. If you give lapatinib to mice, tumor cells upregulate FAM83 and become resistant to all EGFR inhibitors, okay? And the only reason to discover this is because we did it in 3D. Okay, so it is an oncogene family which interacts with CRAF, PI3K, and confers resistant. And we have 4 more, and the Chinese now have gotten interested in this, and they're giving us money, and they're taking my kids back there to find the other ones to see if they could do something. This was supposed to be shown to you when I showed my glucose stuff. I have no idea what happens to my computer between the time I was sitting there and the time I get up there. It's either Apple or me. But anyway, that's the paper I was telling you in 1976, Science, where I showed that there is no difference in this pathway, okay? Now, it's getting really late. Oh, I still have a little time, okay. ECM is here. Tissue-specific genes are all there. How do they talk to each other? So this has taken about 30 years. Wonderful postdocs, graduate students who have worked in these, and we have answered a lot of these question marks. In 1990s, we discovered ECM response element, and nobody has paid attention to those. In the promoter of beta-casein gene, we showed an enhancer, and when we put that enhancer to a reporter gene, we put it in the cytoplasm of a cell, we give them prolactin, nothing happens. We add laminin, nothing happens. But if we put it in the nucleus, in other words, we make a stable transfectant, not transient transfectant. And now we add prolactin, nothing happens. We add laminin, it goes up 150-fold. So ECM outside is talking to transcription factors in the nucleus. Now let's see how that goes. So this, we began to ask the question, ECM here, nucleus here, somewhere, what on earth, oh no, here, somewhere, how do they actually talk to each other to allow formation of milk? So let me go back. Come on, go back. You just messed up my talk. God, how am I going to do this? Okay. So I had a physicist come to my lab. Very, very smart gal. And I think I said this 2 years ago when I was here, so you forgive me if there are any physicists in the room. But I say that the way to hell is paved by physicists who think they are doing biology. They are usually failed physicists, except in the old days when they, because I have had physicists in my lab who have been so dumb, they even don't go and run a Western blot and they want to solve the problem of all biologists. I mean, that's unacceptable. But this person, I have had two of them who are good. One is now is just got his tenure in Spain. And this one has become a hotshot in NIH. So she came and she said, Mina, when you have a single cell and you dump the inhibitor, what happens? I said, well, I don't know. She said, well, if you add it 2 days later, when do you stop not seeing a response? I said 36 hours later. But we can kill the tumor cells if we have a complete tumor and a normal cell, either in 3D or in mice. If they have made it, these same inhibitors actually kill the tumor and don't kill the normal, the way I showed you, okay? So there is a very good lesson in reversion because we can discover new therapeutic pathways, okay? Anything that reverses can help you to kill the tumor cell and not normal. So she said, I'm going to find out. I said, look, it's a single cell in this huge gel. She said, but I'm an imager, I'm going to do it. A single human breast cell put in a gel. Did you know that your breast cells could do that? It's either cell line, one of our cell line, or primary breast. The minute you put them in a gel, the ECM starts interacting, pulling the thing on top of the cell. A single cell becomes polar. It circles and circles and circles, and it's incredible. One cell becomes 2. 2 cells become 3. They don't become 4. They revert to a stem phenotype. Every one of them. And that's how you reorganize the breast after the babies are gone away the first time. Because all the cells go away and a few of them are here, and they're in this fat, which has the softness of matrigel. Are you still with me? Does that make sense to you? I don't mind if the old people don't understand. I only mind if the young people.
What's the time scale?
I'm sorry?
What's the time scale?
That was 10 days.
10 days.
Yeah. Okay, now, here are the normal and malignant. In normal, you see how they are attached to each other? They don't separate. Here are the tumor. They completely separate. So the polarity and adhesion are the basis of the scaffold on which you make a tissue. So when we revert those, they start doing this, okay? So we said, if we are right, and it's polarity and adhesion, let's test them. So when we take part 3, which is a polarity thing, here are the gorgeous controls. Here is the movement, like this. We destroy part 3 or do whatever it is, you inhibit and look at it. We do the same with E-cadherin. When it's good, it does this. When we take it away, it does that. And here is the gal who did it, Candace Tanner. She now has her own big lab. She has huge whatever. And people who used to see the paper and say, Mina, this is a revolution. And I would say, meet the person who did it. She came from Trinidad, and she's a product of her microenvironment. Father was an engineer, mom was a school teacher, and ever since she was born, everybody looked like her. It didn't matter, all these nonsense we have in this country. And parents said, you are going to be a physicist, you're going to be a physicist. And she was good at math and everything, and she's a brilliant physicist who is doing some really amazing stuff. She just was at Berkeley, I couldn't go, but everybody said, amazing, she has discovered so many pathways and what. Anyway, so why cells stop growing to make this three-dimensional stuff? We now know how they do this, but why do they stop growing? Well, we came up with a model where we put very low level of matrigel or laminin in collagen. By the way, matrigel has no secret. The important thing is there needs to be a gel of a given quality, and you then add laminin, okay? So we put the cells in a monolayer. We developed what we call on top, which in fact something that a lot of people thought Joan Brugge's lab invented, but Joan learned it in our lab. So we did that, and we now can do experiment where the cells are initially in a monolayer, and when you add laminin from the top, they do this, okay? So what did we do? We discovered that there is indeed actin in the nucleus. And you know, this has been a horrible, horrible controversy for 50 years. People have been saying, sticks, it does this, and a lot of paper, even before ours, have come out that in fibroblasts, they act one way, in other. So this lovely gal, Canadian, came to the lab. She showed that nuclear actin only can be seen at this high level if you have the cells growing. The cells have a very low level of nuclear actin, and these are VRDU, which is a measure of growth. So she adds laminin. She found that in 2 hours they go down, the nuclear actin. The cytoplasmic actin follows, and when the nuclear actin reaches that level, the cells stop growing. Now, ask what is the mechanism. I only know some of it. It's through PI3 kinase, it's through exporting 6. When we do whatever, this is going to come out now in Cell Report. We actually can see the difference in half an hour now. If laminin stops growth, it means that tumor cells that continuously growing are not responding to laminin. It's that pathway that actually tumor cells don't respond to.
Is that G actin? G versus filamentous actin, it looks like?
G what?
Unpolymerized actin.
You know how hard it is to see the actin in the nucleus? We find it's unpolymerized. Well, the little that we have done a small a storm, we have done palm, we have done everything. What we find is we find single molecules of actin, doublets of actin, and triplets of actin or quadruple of actin, where they go like this, they bend. But what is the significance of that? You know, we haven't actually published those data because I'm not, to give it to him to do structural.
Can you alter the process by doping the laminin with type 4 to stiffen it? What happens then?
I haven't done that, but the kid that is now in Argentina, in Brazil, and has his own lab who has done these, he is actually setting up to do those experiments. And he got his professorship, and he's doing very well now. That's especially, I put his name as the senior author, but he did all of the work in my lab. He's going to get his tenure, they told him, so I'm very happy he's going to do all of those. I'm getting too old, Joe. You have to understand. Okay, so here are in this three-dimensional structure, you see how little actin is here. Now, if you put an actin in here, which doesn't have the exit thing to get out, okay, it has a mutation and can't get out, the cells don't stop growing. They act like this. If we revert these cells, they do that. Okay? So you have to bring the level of actin to a certain thing. Actin is now known as a transcription factor, is in all of the different kind of transcription complexes inside the nucleus. You add laminin, in no time at all, actin comes off. These transcription factors act very differently. We have shown for STAT3 and STAT5 that when we add laminin, those things, and then they allow the milk protein to get produced. So this is a very lovely paper, and you will. Okay, now, I have talked all this time, and I have told you about this beautiful, beautiful three-dimensional thing. Still, what is the pathway? How do we close the loop? So this lovely gal said there has to be microRNA, and this paper is now being reviewed in eLife. It's this big. It's the only journal that would probably, if you send it to Nature, and they said it's too long, make it into 3 papers. We decided not. So we kept it together and sent it. So all right. Now you remember this. Remember all the reversions. So she made a regular array, and then she made microRNA assay of the library of microRNA assay, and the long and short of it is she had 10 of them that were regulating these different molecules that were in common with all of the reversion. In other words, we revert with beta 1, we get reversion. We revert with EGFR, we get reversion, etc., etc. In each of them that we do the arrays are not the same. They are doing it by different way, but the end result is the same, okay? They integrate in a very interesting way. I mean, our cells have all those mutations, right? Okay. So she said, what do they have in common? Another postdoc did that. They have published it, 70 to 150 molecules in common. I'm going way over my time, although it's not past 5. But these 3, she made antibody to all 10. Then the 3 that were high in tumor and were low in normal, she decided she will look at them and see what happens. She puts this microRNA in the tumor cells, they revert, and these 2 come up. She puts this one in there, those 2 come up, just as I have been telling you, okay? So I did this for you quickly. It's MIR34C, MIR30E, and MIR144. What do they regulate down here? They regulate 2 very nasty transcription factors, and I will tell you, each of them does this. Up the stream, HUXD10 has to go up in order for them to be normal, and if kappa B has to come down, okay? Now, 90,000 papers, 900,000 papers, whatever. Who has actually looked at the activity and what regulates P53 in the live tissue, right? I don't think we know. P53, what regulates it? Laminin 5. Laminin 111 regulates laminin 5. Laminin 5 through a series of things regulates P53. P53 regulates laminin 5 and then laminin 1. They're all dynamic and reciprocal. And these 2 upregulate MMP9. MMP9 destroys laminin, right? We have a whole paper in Gene and Development. When we modulate that, the cells revert. When we put it in, they become disorganized. The whole pathway like this is dynamic, reciprocal, and has all these things. It doesn't matter what these things are, okay? So, does ECM signaling direct chromatin structure? How? I said that it had to be both biochemical and mechanical. And remember that little hole I showed you in the beginning in my EM? Those of you who were here, remember that very first slide I showed you So we kept looking at these things. And I began to collaborate with this guy, a German guy who is a real imager, does absolutely everything. So it has taken 12 years, but we published it on the top of Journal of Cell Science January 1st of this year. And there were reasons for that. We hadn't sent it anywhere else. But that issue is all about 3 dimension. And I wrote the introduction for it. So I thought, why not? People should see how this whole thing occurs. So we started looking at these, right? And we saw that they have cytoskeleton in them. The cytoskeleton molecule. So Manfred went to Zeiss and they did a whole lot of things, and God knows how many pixels. This is this is not 2 nuclei. Remember, the nuclear matrix is here. These are nucleoli. But this model got created, and let me show it to you. That's how it happens. It just gives me goosebumps. The cytoskeleton, which from one end talks to ECM, at the other end talks to the nucleus, goes through, and here there are a whole lot of little things that combine with the sun protein. that people had showed are connected to the chromatin. And it is just like that. It's like a donut. Did you know that? It absolutely boggles my mind. We don't know the details of it. You know how much work this is going to require in the future? People have to think of a nucleus not as a single entity in itself, it's part of the whole. Form and function relate to each other dynamically and reciprocally. And I tell you, here are the double store things showing that keratins and SUN1 actually go into the same thing through the nucleus. And here is a little model. One of my former technicians who became my graduate student, now he's more my postdoc, actually made. Okay, so here you have the ECM, then you have the receptors. The receptors talk to the cytoskeleton, and cytoskeleton have interaction with how the chromatin reorganizes. And now it's the dynamic reciprocity of signaling between these, and God knows how much is in between. Okay, Joe? It's a lot for your student, everybody else is a student, the students are students. So here it goes, like that. I tell you, I can now die happy. I am serious. It's taken 40 years. It's still not in your textbook. Boggles my mind. Why? The people who write the textbooks are either interested in their own result, or they are not intelligent enough, or are willing enough to change their mind. We need a new textbook, and I don't have time to write it. Okay, water penetrating on the beach from a NASA satellite and coral. Look at that. Here is a whole mount of the mammary gland. So I like to submit to you that we know everything about the genome. We know the language of the genome, the alphabet of the genome, the primary letters of the genome. I used to be the director of biology at Lawrence Berkeley Lab, and the first human genome actually was being sequenced under me. I was the director of the whole thing. It didn't happen at NIH, it happened at DOE. And we were one of the primary DOE laboratories that started sequencing. And then 3 of them got together, including Livermore and Los Alamos. These 3 make a center. The center is at Berkeley, and it was under me, and I kept saying to them, I can't go and talk to Congress and say everything will be answered. It answers a lot, it has told us a lot, but look at the wing of a butterfly. That pattern, those things all have the same genome. Look at your finger and your nose. Look at yourself in the mirror. You're a miracle. There is wisdom in your nose, there is wisdom in your mouth, there is wisdom in your liver. That's why evolution has done it over the years. And the architecture is the message. And in salute to Joe, what makes the architecture? The ECM. And a whole lot of other things. So what an opportunity for the young and the passionate old. That's me. A whole new horizon to explore, so go to it. Don't say this guy did it, Mina did it, Bob Weinberg did it, that person did it, Joe did it. Do it, okay? Do it. And I couldn't get grant for 16 years, and they're still taking my money away, but it has been a wonderful journey. It has been difficult, and I will show you my favorite cartoon I always show. So the guy, you know, I used to be the cat. You see that face? And these were the authorities. Now, the sad thing is I have become an authority, so don't listen to me. Honest to God, because I would welcome a change in this model, a change in this way of thinking. Somebody else can come and work, or you, anyone in that audience, and we could modify it, we could move it, we could elevate it. So it's, that's how it is, right? So this used to be my group. Now I have about that much, and that's my kid. And I put, that's the kid who did the acting, and I give them all halos except myself, because they have done a lot. And I wish I could have talked to you about galectin. Did you see that galectin paper we did on the cover of PNAS last year? It's so beautiful. This guy did it. and he now is professor in India. Okay, there's my family. And I don't have 5 kids, 5 grandchildren, I have 4. 2 from my son, and these 2 from my daughter, and my hubby, who is the head of the GI at San Francisco. I always thank them, and I say, I think they still like me, despite the fact that I have been working all the time. Okay, and this is Lawrence Berkeley Lab, which is decidedly, it's not Livermore, okay? They don't have this, they have that beautiful whatever. They don't do the kind of biology we do. And should I tell them my joke again?
Sure.
Just one. Okay, so they took the dome of the first accelerator that smashed an atom and put it on the top of the advanced light source. So I'm sure you know about this, and you do a lot of structural biology here. And I say to people, the physicists know the difference between Livermore and Berkeley, but even secretaries of energies mix us up. So at the end of my talks, I say to them, what does this remind you of? A breast? Hey! So only a woman gets away with this. Anyway, especially but the physicists now say to me, Mina, we looked at this thing for 30 years and it never occurred to us. Now we can't look at it without, I say you can do worse, you know. Okay, thank you very much. You're a very good audience, very patient, but he allowed me to talk a little bit more, and thank you very much. They heard the whole story. So I'm happy about that. And everyone, you know, the 400 papers, they are not all good. But you can go and find out about of every one of these, a few papers that support them further. Okay.
Yes, thank you very much for a very inspirational and I think very interesting thing.
Okay.
So we're going to have a reception afterwards, so Mina will be there. So let me hold questions. And you can
it would be good. Okay.
We got one last thing to do. First, Joe's going to say a couple words. Before Joe says a couple words, we'll put him out of that.
We need pictures, so will you please come up here, Joe?
Yes.
Come here and somebody take a picture of the 2 of them, and I'll stay out of the way.
So, well, we should get a picture with all the figures. But, Joe, I just wanted to give you this. This says basically, thank you, Joe, from the faculty, from the staff, and from the students here in the department at Yale. Because as you've seen today, I think you've been such a mentor to so many and such an influence. So congratulations. And
thank you very much.
Hold on. Joe has slides too. We can't talk without slides.
Only 4.
Now you know what I do.
My speed is 2 seconds.
I do it for you guys.
Okay, there you go, Joe.
Okay. Well,
I have been advanced with you for 44 years.
As you can see, I had 42 years here at Yale, all of them in the pathology department, all of them only with 2 chairs. Vince, who hired me even though he has second thoughts, and still does, and then Mike for a few years, and then John. It's been really a pleasure for me. There have been ups and downs, but by and large, it's been really a wonderful ride for me. I've done things and met people I never thought I would. I'd just like to say a few words, and then we can get to the drinks. I'd really like to thank my family, and this is my life partner, my soulmate for 50 years. That's Lucille, and stayed with me for 50 years, which is remarkable in and of itself. She keeps me grounded and lets me have some semblance of normalcy on occasion. I have a son, Daniel, who you'll meet at the reception. Now 43 years old. He got married 5 years ago. We're expecting their first child, a daughter. Dan is a musician and an excellent carpenter and construction guy. He's made several pieces of furniture for us. And come to the house, Olivier, you can see his bookcases and condensers. Marvelous guy. We trained together in Taekwondo, and that was the only time he could hit me, and I wouldn't hit him back. Okay. I have a daughter, Jessica, who married Carl Hagelin, an MD PhD student here in this department with Jack Rose. He was in Jack's lab in Yale for 10 years. I figured he was okay at that time to marry my daughter. I told him if he hurt my daughter, I would kill him. He knows that. They have a beautiful boy, Willem, who's 7 years old now, and is an absolute joy. It's just marvelous. I missed a lot of Daniel's upbringing and Jessica's being in the lab, and I get to see what it was like from Willem. So they really are the mainstays of what keeps me going. We all stand on the shoulders of those that went before us, and I had 3 wonderful mentors in my graduate training. Joe Kincannon. No? Okay, well, Joe Kincannon is up here at St. John's. I did a master's with Joe. He was really a true gentleman and scholar and just an excellent teacher, and I aspire to be have his attitude about teaching. At IU, where I met John as grad students in the second floor of the chemistry building, Terry Jenkins was my mentor. Terry was an enzymologist trained in Oxford. And the main thing Terry taught me was independence. I showed up at lab, and he told me, yeah, you can work in lab, work on a project that no one else in lab is working on. And I'm going to Oxford for 18 months to take a sabbatical. So the lab was very helpful, and the postdocs and the faculty in the department were very, very helpful. And the last mentor I had was Heinz Furthmeyer here at Yale. And those of you who know Heinz know he was a hard man. Meant what he said what he meant. Incredibly critical, but incredibly loyal and helpful. And when I started a lab here at Yale, he gave me a technician.
I liked him.
And he gave me a lot of major equipment, which got me started. So I really owe a lot to Heinz. While I was at Yale, I found it to be an incredible interactive place, and there's really no boundaries in working with other labs. And early on, I started to work with people in pathology. It was Heinz, Virginia Lavosi, Darrell Carter for the gray hairs and silverbacks in the department, Ken Barwick, John Morrow, we published together on 4.1 and Spectrum, hard to believe. And lately, as recently as Demetrius Braddock, doing some work with MPP1. I then got to know a lot of people in the medical center and the university, and really have some long-term collaborations with Jim Jameson, with Laura Ment in Pediatrics and Neurology, where Laura brought me a project, basically, and we had a program project for maybe 4 iterations. It's really marvelous about neurovascular development. Emma Pinter, another neonatologist, was interested in diabetes and the effect of diabetes on the developing fetus and heart development. And that really gave us a project for a number of years. Immunology, Charlie Janeway and Kim Bottomley were very helpful in schooling me in mouse immunology and EAE. And that was basically another R01, which lasted for 4 iterations, along with my careers in immunology. Other people are listed here. It's been really a wonderful pleasure for me to do this. I can't say enough about other people in the lab. Lenny Bell was a fellow with me in the late 80s, and at night we would sit in front of my Apple computer and we would think about what we'd do if we had a company. And we had a folder, and it was labeled Fantasy. And that basically became Alexion Pharmaceuticals. And I had a 25-year association with Alexion, Lenny, Steve Squinto, Scott Rollins, and several other people at Alexion. And it really enabled me to learn about complement, something I could never get funded for, and actually do some good with patients. The postdocs, fellows, and techs and students in the lab were really the driving force for the lab. And I can take some credit, but minor credit for what's gone on in the lab. They really were the driving force and really the soul of the lab. And a couple of them are sitting here, Olivier, Dita, and there are many, many more, and some of them are here in the reception.
Wow.
It's a reasonably good list. The postdocs were just really all pretty much spectacular, starting with Bruce Pratt and ending up with now Elias Theodoro, and we're starting on a new neutrophil project. The students were just spectacular. The MD PhDs, Dita is one of them. Just really wonderful people. Anna's here. Really added so much to the lab. Undergrads. My first experience with undergrads was at Yale. I've had 30 undergrads in the lab, and they're just incredible. They're bright, assertive, interesting, uninhibited, and they've all done very well. Many of them went on to what?
Free.
No, I had to pay some of them, which was money well spent. One of them, I don't know if he's here today, Dave Stillman, worked, published 3 papers with us, went to med school, came back as a pediatric surgeon here at Yale. So interesting. All really done very well.
Joe, you are not connected.
Pardon me?
You're not connected.
Well, I'm not connected to a lot of things.
I'm very sorry.
Okay, you
How come he doesn't come and tell you you're not connected?
My wife tells me that many times. Yeah, that's all. Okay, ready? No? All right. Where was I? Doesn't matter. Technical staff. They're the soul of the technology history of the lab. I mean, as PIs, you do some things, but you forget things. I know a little protein chemistry, a little tissue culture, but the people coming in really know this stuff. And I've had wonderful people throughout the whole career here. Mary Davis and Adeline Tucker were in the lab for over 2 decades. We were supposed to retire together, and she fooled me. She left early. The last 10 or 12 years has been with Sandra Canosa and Mike Machad, and these are really impressive people. Sandy, as a lab manager, was wonderful. She really was the intellectual mother for many of the undergrads in the lab. And Mike, with our mouse studies, we had 7 or 8 strains going on. Mike could handle them all, and with a smile, and always bringing in Neil's Donuts, and he makes his own ice cream. We had Guinness ice cream. I highly recommend it. Administrative staff. Fran Storm, a wonderful person, helped me with a lot of the editorial processes I had to go through with the different journals, with the teaching. And Fran, incredibly loyal. I swear she would take a bullet for me. Corinne Brewery replaced Fran after she retired, and she's just an upbeat, wonderful person, takes on anything with gusto. And now recently Karen Reynolds at the transition from my lab shrinking and losing the teaching stuff, but has done a wonderful job. I really owe a lot to everybody here. And the only thing I can say to you, everyone, is thank you all. It's really been a wonderful ride. I'll still be around for a number of years. We got funding now for this new project, and so I ain't dead yet.